Department of Ops and Gynae, Shohid Sohrawardi Medical College and Hospital, Dhaka. Welcome you all to First International Young Gynecologist Scientific Conference 2022, organized by Obstetrical and Gynaecological Society of Bangladesh. Now, our session is on gynecological malignancies, which will mainly focus on recent update of important gynecological malignancies. It's my pleasure to conduct the session, to hand over the microphone to Dr. Nandita Pal, Medical Officer, Department of Ops and Gynae, Shohid Sohrawardi Medical College and Hospital, to moderate the session.
Thank you, Dr. Sharifa, for your kind introduction. It's my honor to introduce our honorable advisors of the session from Gynaecological Oncology Department, Professor Dr. Sabira Khatun, Founder Chairman, BSMMU, Secretary General, Gynaecological Oncology Society, Bangladesh. Professor Dr. Ashrafun Nessa, former Chairman, BSMMU, Professor Dr. Rehana Parvin, former Head of the Department, NICRH, Professor Dr. Shirin Akhtar Begum, Chairman, BSMMU, Professor Dr. Fawzia Hussain, International Affairs Secretary, OGSB, Vice President of BDS CCP, Professor Dr. Janatul Firdaus, Professor BSMMU. Our session coordinator, Professor Dr. Shahna Parvin, Professor, NICRH. I am requesting our House Supervisor, Dr. Sharmin Akhtar, Assistant Professor, Sharmin Akhtar, Assistant Professor, ICMH, to accompany our advisors to the designated chair. Thank you, Madam, for having your seats. Now, I would like to request today's chairperson, Dr. Sylvia Hussain, Assistant Registrar, NICRH, and to come to the dais. Dear audience, in this session, we have very informative discussion. We have 5 speakers. Speakers are requested to maintain their time strictly. Now, I am requesting our first speaker, Dr. Sanjay Gandhi, Director, Scientific Affairs and Public Health Access, GSK, to deliver his presentation. Thank you, GSK, for your sponsorship. Dr. Sanjay Gandhi.
Can you hear me? Can you hear me?
Yes.
Okay. So you can start.
Yes. Just confirm if you are able to see my screen.
Yeah, you can start now.
Okay. First of all, thanks for being inviting us for this particular conference and congress. And my sincere apologies, I am not unable to be attending in person as such. So without taking much time, thanks for this invitation and wish you all the best to this young gynecologists who have initiated and then look their presence globally, not only in Bangladesh but look in coming years in globally. So my topic is updates on human papilloma virus vaccines. Just a minute. Yeah. So before we start, let's have a WHO cervical cancer elimination strategy, and I believe that this document must be reviewed by all of you, or if not, then should be. The strategy is very simple: 90-70-90, and this is the first time ever the world is committed to eliminate cancer, and it can be done. with a simple strategy of vaccination coverage to be reached by 90%, 70% cervical cancer screenings, and 90% of the treatment we will be taking care of the, and there is a possibility that this disease can be eliminated from the world. Now it's a big presentation, but because of the paucity of time and the time allocated, I'll be only touch basing on two aspects about the WHO PQ HPV vaccine which are available, about Cervarix, the vaccine which will be used in National Immunization Program of Bangladesh, and the real world evidences which has been recently updated. Now, coming to the HPV vaccines, there are three Gavi supported WHO pre-qualified vaccines. Two are bivalent and one is quadrivalent. What does that mean? There are two vaccines which contains two HPV types and one vaccine contains 4 HPV type.
Sanjay.
But if we consider the oncogenic type, from the oncogenic 18 been adopted or approved by the NITAG of Bangladesh and now will be introduced in National Immunization Program for Bangladesh. So basically it contains 16 and 18. There is a specific adjuvant which is ASO4. What does that mean? This adjuvant is a kind of an immunomodulator which mimics kind of an antigen response or antibody response over a period of time. It is WHO PQ since 2009. The vaccine that will be coming in the National Immunization Program will be a 2-dose schedule, and it doesn't contain a preservative. What does that mean? That means once you open the vial, all the 2 doses needs to be used within 6 hours. If not used, it should be discarded. So important point to be noted. Then the cold chain needs to be maintained between 2 to 8 degrees centigrade. The cold chain space that is required by this particular vaccine, which will be used in National Immunization Program, is the lowest in the all among all the 3 vaccines, reducing the storage requirement by 34%. The VV vaccine vial monitor, which is there on the vaccines, is the label is 30, which means that if because of some reason there is a disruption in the cold chain storage and it goes up to 37 degrees centigrade for 30 days, in which case then it will be in the discard position. Otherwise, the vial remains intact. It can be used. Now, shelf life is of this vaccine is for 5 years, the maximum among the 3 vaccines. The vaccination schedule is from 9 to 14 years with the good flexibilities of the second dose giving between 5 months to 13 months. The vaccination schedule is a 2-dose schedules before the age of 14 years, and after the age of 14 years, it needs to be given in 3 doses. And if it is an immunocompromised conditions, then it is a 3-dose schedule per se. Now, if you look at one of the parameters to judge a particular vaccine is an effectiveness in the real world, how it's happening and all that, it is 86% compared to in comparison to other vaccines as such, again the CIN3. Now, this is important whenever you try to review an article, ensure that what kind of an outcome variable that is being assessed. Cervical cancer is the best indicator. However, ethically, we cannot continue up to cervical cancers because there is a stage called CIN3. So that it becomes a proxy indicator. So based on that, the effectiveness turns out to be 86%. And one important point, it is not only 16 and 18. This vaccine is able to take care amongst the other oncogenic types of 31, 33, 45. So it says that more consistent and higher cross protections against prevalent infection, persistent infections with type 31, 33, 45 has been observed in countries that introduce Cervarix than Gardasil. Gardasil is a market name for the quadrivalent vaccine. Now, there are 2 components, antigen and adjuvant. Now, adjuvant is important of this particular vaccines. Why it is giving a kind of a long-term immune response per se, and this particular this adjuvant which is being added to the vaccines gives an early response, higher response, and longer response. Now, longer response is very important because we are dealing with a case which is a very broad spectrum, starting around the infection starting around 15 years and then having the frank cancer around the age of 45 years. Now, this is the real world evidences coming for up to 11 years, and you can see that there is a sustainable vaccines level, the antibody titers up to 11 years. And then if you make a comparisons with between the 16 and 18, there are 16 at a higher level and 18 at a lower level. Now, if we translate this data, this is the real data, translate into mathematical model, we believe that this particular vaccines may have an antibody titers persisting for 50 years, so that the lifespan can be taken care of, and this is based on a kind of an evidences where 50 years of near lifelong persistence can be seen in more than 99% of the subjects per se. Now, this is a head-to-head comparisons between the two vaccines, bivalent and quadrivalent vaccines, the Cervarix and Gardasil per se, where it has shown that Cervarix is giving almost 8 times higher antibody titers as the quadrivalent vaccines against HPV 16, and almost 12 times higher in the HPV 18 against HPV 18s per se. Now, there is another interesting trial that was being conducted where 2 doses of Cervarix was being used against 2 doses and 3 doses of quadrivalent vaccines, and which has shown a kind of a superiorly statistically demonstrated for antibody level with Cervarix 2 dose versus quadrivalent vaccines of 2 and 3 doses up to 36 months post vaccinations per se. So again, there is a kind of a higher immune response was being shown. Now I'll come to a real world evidence. Now this is where the actual vaccine effectiveness and the impact will be seen. And I have just picked 3 very recent publications for your information. If you want details, we can share the publications as well. Now the first one is coming from Scotland. Now, Scotland is a unique country where they have started the vaccination at the age of, in the year of 2008, and the screening is being started at around the age of 20 years. So those girls who got vaccinated in 2000, they have entered into the screening phase, and that this country was having the data from the both, like the vaccinated girls who got screened and the unvaccinated girls who were not a part of the vaccination series, what was the status and all that. And what they have found, like the girls who were born in 1995, 96, which entered at the best of the years for the vaccination at the age of 12 to 13 years, and the girls who were born somewhere in 1988 or and those who were not been vaccinated, what they have seen, it's a time trend analysis. The almost like 0.6% prevalence was dropped down to almost 0.06%. That is a kind of an 89% reductions over a period of time post introduction of the vaccines per se. So that is, and this is CIN3. So this is a classical decline that has been seen with the real world evidence coming from Scotland. Now that is not only for 16 and 18, they have shown a classical decline in 31, 33 and 45. So there is an evidence coming in for the cross protections as well. Now coming to the England, now this is another important study that is being published, and this is the first ever evidences coming from an HPV vaccine where they have shown a relative risk reduction in cervical cancer, not CIN3 but cervical cancer per se. Just for your information, the girls who got vaccinated in 12 to 14 years, there was an 87% relative risk reductions in cervical cancers. That means if we do the vaccination and later on the screenings, both put together, we will be able to eliminate the cervical cancers per se. And most important point, this kind of a data publications was feasible because of having the vaccination registries, because of having a screening registries. And it is heartening to know, my recent visit, I have interacted with a senior gynecologist of Bangladesh. They are sitting on the they are sitting in the audience as well, thanks to them. What I understood it, there is a cervical cancer screening. It is not only happening, there is a database, electronic database that is getting created. So maybe in future, Bangladesh may be the first country where this kind of a registries will be able to publish the data which are coming from developed part of the world like England and Scotland per se as such. Now coming to the third study, this Finland, the uniqueness of Finland is this country have adopted both the vaccines, bivalent vaccine and quadrivalent vaccines in different geographies. And one unique feature of this particular country is during pregnancies, they collect blood samples. During the first trimester, each and every pregnant woman's blood samples gets collected. So they were in a unique positions to assess the antibody titers with all the ethical approvals and all that. They were in a unique positions to assess the antibody response later in the life who have got bivalent vaccines, who got quadrivalent vaccines. And what they have found is, now this is the graphical representation of the studies per se as such. Now, if you look at the low down, HPV 6 is a non-oncogenic type, and HPV 16, 18, 31, 33, 45, 52 and 58 are the oncogenic types. Now you can see the 16 and 18 which is contained in the vaccine, both the vaccines, bivalent vaccines, the Cervarix has outperformed the quadrivalent vaccines on the similar lines for all the other oncogenic type which are not part of the vaccines per se. Now, the whole idea about and thanks for this opportunity, the whole idea of sharing this update with this audience is now HPV vaccination is a unique one because it's kind of a sexually transmitted infection kind of a concept. So there is a sensitivities around the communications part of it. Second, it needs to be given an adolescent platform, adolescent groups or girls. So it's in separate groups where most of the immunization programs are targeted to immunization program. So the intervention of the gynecologist, specifically the platforms like young gynecologists, they should be involved in communication. They should be supporting the government of Bangladesh so that it's not only about the coverage. From the coverage perspective, government of Bangladesh is doing extremely well. What is required from this particular group is a kind of an awareness, trying to share about the disease, what the vaccination will done, and not only the girls, the woman who comes, the mothers who are coming with the girls for the vaccination should also be advised for the screening per se. So my summary slide is, what are the programmatic advantages of the vaccine that will be used in the National Immunization Program of Bangladesh? It is the lowest cold chain space required. It has the highest shelf life. There is a flexibility in the vaccination schedules that can be used by the government. And also there is a kind of a price-free commitment to Gavi countries. That's an important concept that is being already the immunization stakeholders are aware of. Now, from the scientific advantage, now we have a real-world evidences coming from England, Scotland, Finland, and I look forward. I'm very, very confident in the sense that this kind of a database will be coming from Bangladesh as well, because you have both the electronic registries. They will be starting an adolescent vaccination registries, and already you have an electronic registries already in place for Bangladesh. Higher immune response in immunocompromised also been seen. Higher cross protections is again has been shown on the Gavi portfolios as such. Again from the safety perspective, I've been working in the vaccines field from last 3 decades. One of the safest vaccines, which I believe, there are many vaccines are available adolescents and amongst the adults and amongst the kids and all that part of it. One of the safest, we can bet that one of the safest vaccines in the groups amongst the vaccines is Hpv vaccine. And this is not applicable only to cervix. Across the globe is about that part of it. Now, in case you find of any adverse events following immunization, because this will be launched, the program will be launched next year, please reach out to this email IDs. If you forget, please reach out to us. We are always there. My colleague who is in Bangladesh, Dr. Kabir, can also be reached out. Thank you all.
Thank you, Dr. Gandhi, for your resourceful presentation and wonderful time management. Now, I am requesting Dr. Aisha Siddiqa, Medical Officer, NICRH, to discuss her presentation. Dr. Aisha Siddiqa.
Thank you, Dr. Nandita, for your kind introduction. Assalamu alaikum and very good morning to everyone. Today, I will talk on, sorry for the inconvenience. Oncology session চলে যান এখানে আছে হ্যাঁ যান এই যে হ্যাঁ এটা ফুল স্ক্রিন Today, I will talk on predictive factors for optimal cytoreductive surgery in advanced epithelial ovarian cancer. Ovarian cancer is the 8th most common cancer in women, according to Globocon 2020. More than 75% of patients are diagnosed in advanced stages with high mortality rate, that is around 70%. We all know that surgery is the mainstay of treatment for ovarian cancer, and residual tumor after surgery is the most important prognostic factor. Basically, it is not only a prognostic factor, but currently it is considered a surrogate for survival. So all international guidelines recommend to achieve complete, that means no gross residual disease after surgery, or optimal resection, that is up to 5 millimeter could be left during primary debulking surgery. This is a meta-analysis. Here we can see, we showed the impact of residual tumor on survival. Here we can see that when there is no residual tumor, the 5-year survival is quite good, that is around 63.7%. But if the residual tumor left more than 10 millimeter, it sharply drops down to 21.3%. So what is our aim of management? Our aim is to achieve complete debulking or optimal resection during primary debulking surgery, or to avoid unnecessary laparotomies with suboptimal resection. Now comes the question, how? First of all, we need to define some factors that are directly related to optimal resection, which could be patient-related factors, tumor-related factors, and infrastructure and health resources-related factors. There are some defined criteria of non-resectable abdominal disease, which are involvement of the superior mesenteric artery, root of the small bowel mesentery, diffuse peritoneal carcinomatosis, and also multisegmental parenchymal disease like liver, lung, and brain metastasis. But there are some areas which are potentially resectable and which could be extra-abdominal, like inguinal lymphadenopathy, focal parietal pleural involvement, and this could be intra-abdominal parenchymal disease also, like liver capsular metastasis. These areas are potentially resectable, so we need to identify these areas for unresectable area. Now comes the question, how can we assess the extent of disease? First of all, thorough clinical examination of the patient, ultrasonogram with expert sonologists with the help of some modern imaging technologies like CT scan, diffusion MRI, PET-CT also. Last of all, staging laparoscopy. This is a restorative evaluation which showed the specificity of CT scan for identification of preoperative peritoneal carcinomatosis and showed that this is quite good, around 99 to 98%. Another study showed the comparison between MRI and CT scan and showed that MRI has better accuracy than CT scan. We can also do FDG PET-CT, but it has some of its own limitation. Last of all comes the staging laparoscopy. This is the most advanced technology that we can use to assess the extent and localization of the peritoneal disease, because all the modern imaging technologies that we have already discussed, sometimes they give us high false negative rate in case of assessment of intraperitoneal staging. During staging laparoscopy, what we do, we use some scoring system to identify the tumor distribution pattern within the peritoneal cavity and also calculate the tumor burden in the peritoneal cavity. One of them is the Fagotti score. Here we identify the tumor location within the peritoneal cavity, 7 areas like peritoneal carcinomatosis, diaphragmatic, mesenteric and omental disease, bowel and stomach infiltration, and liver metastasis. And then we give a score either 2 or 0 according to tumor distribution pattern. Total value is between 0 to 14. If the value is more than or equal to 8, it is directly related to suboptimal resection. Another commonly well-known scoring system is peritoneal cancer index scoring system. It is also known as Sugar-Baker score. Here we divide the whole abdominal cavity into 13 regions and identify the tumor each location, also calculate, measure the size of the lesion. Total score is between 0 to 39. If the score is more than 10, it is positively associated with poor prognosis. A recent multi-center assessment, they developed a predictive score model which includes 3 clinical criteria and 8 CT scan criteria, and they showed that this predictive score is directly related to the percentage of residual disease during surgery. Now comes the patient-related factor. Sometimes elderly patient with multiple comorbidity, they cannot cope up with such type of aggressive surgery. The German study also showed that this type of patient ultimately ended up with high mortality. So it showed that sometimes standard strategy fails in case of vulnerable patient. Now comes the tumor biology-related factor. Sometimes we operate patient, give chemotherapy, but they recur within 6 months. That means there are some molecular factor within the tumor itself, which this is the treatment outcome and survival. Last of all, there are some accessory factors like surgeon or team-related factor, health resources, institutional infrastructure, which can also limit our surgical effort. In conclusion, I want to say prediction of surgical outcome is currently one of the main issues in primary debulking surgery for advanced epithelial ovarian cancer. But each method of preoperative assessment and surgical planning has its own limitation. So imaging modalities, scoring system, tumor biology, and patient characteristics may assist clinician when difficult decisions need to be taken. Thank you all. Thank you for your patience hearing.
Thank you, Dr. Aisha, for your precise presentation. Now, I am requesting Dr. Shushmita Bardhan, Medical Officer, NICRH, to deliver her presentation.
Thank you, Nandita, for your kind introduction. Assalamu alaikum, namaskar, very good morning, and welcome you all to my today's topics, gestational trophoblastic neoplasia, a highly curable malignancy with management dilemma. Gestational trophoblastic neoplasia is the malignant form of gestational trophoblastic disease, which includes invasive mole, choriocarcinoma, placental-side trophoblastic tumor, and epithelial trophoblastic tumor. And 50% of the GTN occurs after molar pregnancy, but 50% can occur after term pregnancy, abortion, or even ectopic. So when we call a post-molar GTN, if Ecg level plateau for 4 consecutive values over 3 weeks, or Ecg level rise more than or equal to 10% for 3 values over 2 weeks, or ECG persistence 6 months after molar evacuation, or histological diagnosis of choriocarcinoma, placental site tropoblastic tumor, or epithelial tropoblastic tumor. As GTN can occur after non-molar pregnancy, so which woman should be investigated for GTN after a non-molar pregnancy? According to guideline, any woman who develops persistent vaginal bleeding after any pregnancy event is at risk of having GTN. So what to do? At least a beta ECG should be estimated. Yeah. After GTN is suspected, what investigation should be done? At first, ultrasonogram of whole abdomen, X-ray chest, if positive, then CT chest. Sometimes X-ray chest may be negative, but patient have symptoms. Then we should also done for CT chest. CT scan of whole abdomen with contrast, and if CT chest is positive, CT or MRI brain. So these are some pictures of advanced imaging of GTN, and this is lung metastasis and brain metastasis. So treatment of GTN is based on FIGO staging and prognostic scoring. This is the FIGO staging system for GTN. And this is the most important prognostic scoring because the treatment depends upon it. There are some prognostic factors: age, antecedent pregnancy, interval pregnancy from index pregnancy, pre-treatment ECG, largest tumor size, site of metastasis, number of metastasis, and previous failed chemotherapy. The more the age, the more the interval, the more the ECG, the risk will be more. So low risk means less than 7, high risk 7 or more, ultra high risk 13 or more. The treatment of low risk GTN is single agent chemotherapy with methotrexate or dactinomycin, and first line therapy is methotrexate, folinic acid, 8-day regimen, and second line is dactinomycin. So when to change from first line single agent to second line single agent? When there is good response to initial therapy followed by ECG level plateau or raise, but ECG level less than 1000. And when to change from single agent to multi-agent therapy, that is immunotherapy, when there is good response to initial single agent followed by rapid rise of ECG, but ECG 1000 or more, and initially poor response, or if there is metastatic change. So adequate response of methotrexate means a fall in the ECG level by 1 log after a single course of chemotherapy, and resistance means if 2 consecutive courses of methotrexate, the level is less than 1 log. The high risk for high risk GTN, IMACO is the preferred regimen, and if IMACO fails, EPMA or IMAP is preferred. If above mentioned regimen fails, then salvage therapy should be considered. These are some salvage therapies. This is the IMACO protocol. And ultra high risk GTN is a group of GTN when there is prognostic scoring is 13 or more. And usually these patients have extensive metastasis in brain, liver, and other sites. And if we start IMACO here, sometimes there is extensive hemorrhage on the metastatic sites and patient may death. So here also the score is very important. So we should start gentle chemotherapy as a induction chemotherapy first to IMACO. So if we scoring is not done properly, the patient, we know that GTN is a highly curable disease, but if we give IMACO directly on ultra high risk, we may lose our patient. There are some options of brain metastasis, IMACO with increased dose, intrathecal methotrexate, whole brain radiation, salvage surgery. And now, what is the role of hysterectomy in GTN? To control the uterine hemorrhage, sepsis, and tumor burden, and it is the primary treatment of PSTT and ETT. But we should remember that hysterectomy is not the end of the treatment. After hysterectomy, the usual chemotherapy and follow-up should be necessary. Now the question is when to stop treatment after ECG normalization. For low risk, 3 additional cycle of chemotherapy, high risk 3 to 4 additional cycle of chemotherapy, and ultra high risk 4 additional cycle of chemotherapy should be given. And this is called consolidation therapies. And why this? It is to prevent relapse. There are some dilemma regarding the Ecg elevation. One is phantom Ecg and one is quiescent GTN. Phantom Ecg is the false negative Ecg. When there is after evacuation low level of beta ECG, but usually the ECG level below 200, and here the hyperglycosylated hemoglobin ECG is normal. So in quiescent GTN we should not give treatment. PSTT and ETT is separate entity. It is different from choriocarcinoma invasive mole, as there is a diagnostic dilemma, and they may develop years after pregnancy, and there is beta ECG is a less reliable marker here. And they are relatively chemoresistant, and curative treatment is by hysterectomy. Regarding immunotherapy and targeted therapy, there are immunotherapy, PD-1, PD-L1 inhibitors, and high-dose chemotherapy with peripheral stem cell transplant is now effective for multi-agent chemo-resistant high-risk GTN. This is a study which is done on Iran, and they showed that response rate in low-risk GTN present patients was 100%, and high-risk patient is more than 90% if patients are treated in referral centers. So my take-home message is the GTN is one of the most curable tumor in women, and any suspicious PV bleeding after incomplete abortion or term pregnancy, please do a beta Ecg. And before starting chemotherapy, diagnostic workup, staging, scoring is mandatory, and rescoring should be done in every step of treatment change. Thank you for giving me the opportunity. Thank you.
Thank you, Dr. Shushmita, for your informative presentation. Now, I am requesting Dr. Jakanta Faika, Medical Officer, Mugda Medical College Hospital, to narrate her presentation.
Thank you, Dr. Nandita, for inviting me. Assalamu alaikum and very good morning to everyone. So today my topic is to discuss about endometrial thickness as a predictor of endometrial cancer. Endometrial carcinoma is the most common gynecological malignancy in the developed countries. However, its incidence is increasing day by day in developing countries as well, due to especially in the patients with risk factors. Although we all know that most of the endometrial carcinoma is diagnosed in postmenopausal women, around 5 to 30% cases are diagnosed in premenopausal women with a risk of 1.33%. Early and accurate diagnosis is the first fundamental step to ensure early adequate treatment and maximize the overall survival. There are different diagnostic modalities for endometrial carcinoma. However, histopathology is the gold standard technique. Anti-VS is a reliable method which is widely accepted both for the health professionals and also for the patient as well. Now coming to the cutoff of endometrial thickness to predict endometrial cancer in peri and postmenopausal women. For postmenopausal women, this cutoff ranges from 3 to 5 millimeter, and in premenopausal women, cutoff ranges from 3 to 10 millimeter in various studies. However, very little studies have been undertaken till far to detect the cutoff in case of reproductive age group and perimenopausal age group. Here it is the research article from Italy. They have shown that if we take the endometrial thickness cutoff for more than 4 or 4 millimeter, then its sensitivity and specificity is very high. So another article from India, here they have discussed about the perimenopausal women endometrial thickness, and they have shown that if we take the cutoff about 10.5 millimeter, then it has the highest sensitivity and specificity as well. This is a review article from Italy again, and they have shown that in case of premenopausal women, we should do the TVS ultrasonogram at 4 to 6 days of menstrual cycle when the endometrial thickness should be at thinnest. However, to predict any precancerous and cancerous lesion, for premenopausal women, we should do endometrial echo. And in case of postmenopausal women, when we see the cutoff for 5 or more than 5 millimeter, then it has highest sensitivity, and at the same time it reduces the rate of invasive procedure by up to 17%. So this is the picture of postmenopausal endometrial thickness, and in this slide we can see that this is the thickened endometrium. And here are some special situations like postmenopausal women and with hormone replacement therapy. Usually cutoff thickness ranges from 5 to 10 millimeter, but maximum studies have concluded that if the cutoff we use more than 8 millimeter, and women with HRT with bleeding, they should undergo hysteroscopy and biopsy. Premenopausal women on tamoxifen, data have shown that no statistically significant difference in the incidence of endometrial cancer patients treated or untreated with tamoxifen. So no additional endometrial monitoring is recommended unless the symptoms of abnormal uterine bleeding is there. So another situation in postmenopausal women with tamoxifen, If the patient is asymptomatic, if we take the cutoff for more than 5 millimeter, high incidence of false positive rate, so no additional benefit from the routine surveillance. However, any symptomatic women should associated endometrial hyperplasia, well, especially if we have some uterine pathologies like uterine fibroids, adenomyosis, previous uterine surgery. So there is difficulty in obtaining the endometrial thickness and endometrial echo. So in that case, the ACOG guideline recommended that to perform saline or gel infused sonohysterography and hysteroscopy. And another limitation is in case of type 2 endometrial cancer, which can be occur in case of atrophic endometrium. So endometrial thickness, it may not be used as a predictive for type 2 endometrial cancer. So my take-home message for premenopausal women with or without AUB, there is no optimal cutoff for endometrial thickness. So routine use of endometrial thickness alone in prediction of endometrial cancer and precancerous lesion is not recommended. And postmenopausal asymptomatic women, if the endometrial thickness 5 or less than 5, routine follow-up is recommended. However, if the thickness is more than 5 millimeter, then office hysteroscopy followed by endometrial biopsy is recommended. And any women with postmenopausal bleeding, first-line investigation should be done the office hysteroscopy followed by endometrial biopsy regardless of endometrial thickness along with cervical screening. So thank you all for your patient sharing.
Thank you, Dr. Jakanta, for your flawless presentation and wonderful time management. Now, I am requesting Dr. Kaustav Basu, Consultant, Gynecological Oncology and Robotic Surgery Department from Narayana Hospital, to deliver his presentation.
Respected chairpersons, my co-speakers, dignitaries in the audience, colleagues, friends and juniors, good morning to all of you. At the onset, I would like to thank Obstetrical and Gynaecological Society of Bangladesh for inviting me for this session. I'm a gynaecologist and robotic surgeon working with Narayana Health Kolkata, and today I'm going to talk what is sync with the the theme of today's conference, addressing the young gynecologists. So it's about robotic surgery and how can we apply robotic surgery in a gynecological oncological to treat gynecological oncological cancer. So as oncologists, when a patient comes to our OPD, so they have a lot of questions, they have a lot of uh, they're very feared about the disease, right? You all know that. So as oncologists, what goes in our mind? We try to physically examine the patient, we do a biopsy, we do different sort of scans, CT scan, MRI, PET-CT. We try to reach out the diagnosis of the patient. And once the diagnosis is there, we try to offer different form of treatment to the patients. Like we can offer them surgery, we can offer them chemotherapy, different forms of newer chemotherapies like targeted therapies, immunotherapy. But have you ever thought what goes in the patient's mind who is sitting on the other side of the table? When we break the bad news of cancer to the patient thinks, am I going to survive and for how long? Am I going to have pain during treatment? Am I going to back to normal life after the treatment is over? Can I take care of my children, our elderly patients? Am I going to have a lot of hair fall? So am I going to lose a lot of savings of mine during the treatment? So basically what the patient is thinking is concerned. She is concerned about the quality of life, right? So as a physician, as an oncologist, as a surgeon, we should try to balance between the quality of life and the treatment. So we should not give so much radical treatment that will affect the quality of life. And on the other hand, we should not be too much of lenient on the treatment to, if we consider better quality of life. So we should strike a balance, right? And over the years, there has been a paradigm shift in treatment options because we all know with advanced research, as we have all discussed from the morning, we all know that cancer in early stages can be curable because of a lot of advanced research nowadays. So if we can give better survival, we need to think about the quality of life of the patient. Previously, conventional oncosurgeries used to have big incisions that would result in big scars. Now, with the introduction of minimal invasive surgery, quality of life have improved a much. But trust me, if you are a laparoscopic surgeon, you must be knowing when you do endometriosis surgeries, oncosurgeries, it's really challenging. The reason behind this is the restricted freedom of movement of the laparoscopic instruments. Okay, and that would result in a steep learning curve. You need 10 to 15 years to achieve that skill to become a good laparoscopic surgeon. So that is the reason. To overcome those hurdles, the robotic surgical platform has been introduced, and it's been there from 1980s, initially used in stereotactic neurosurgery, prostate surgery, knee replacement surgery. NASA adopted it for telesurgery in 90s, but that failed for warfield in Afghanistan. And then Intuitive Surgical, a company based in USA, they bought the prototype from NASA and they used it, named it as Da Vinci for on-site in-theater surgery. Okay, and FDA got approval in 2000. So Da Vinci is the company which is globally used across across all countries. But newer players are coming in, like the CMR robot, Versius, Medtronics have launched Hugo a few days back. SSI Mantra is an Indian robot. So a lot of changes are happening. So these are the components of robotic surgical system. It's a surgical console, it's a patient cart and a vision cart. Okay, so coming to the surgeon's console, surgeon sits on this console and operates. So if you see the view box, you can see the surgeon sees at the viewfinder and have a 3D imaging of the abdomen, okay, and operates. With the, if you can see the controllers over there, there are joystick. With the movement of those joysticks, the surgeon can control the instruments. And there is on this handrest, there is a display pad which has all the controls. So right at the console, surgeon have access to all the parameters. You can change the diathermy settings, you can change the movement, everything is under control. So although it's called robot surgery, it's absolutely safe because it is totally under the control of the surgeon at this console. Coming to the vision cart, it is seen by the surgeon's assistant scrub nurses. There is a touchscreen monitor. There is a electrosurgical unit inbuilt into it. There is an endoscope controller. So basically, this is the CPU of the robotic surgical system. And the patient cart. So patient cart has 4 arms, 1, 2, 3, and 4. You can see that comes close to the patient in a sterile field. Rest of it is a non-sterile zone. So this is how we drape the robotic arms. Okay, so it's a sterile drape because it comes close to the sterile field, and the arms should be placed one fist away from each other, so there is no collision during the surgery. Okay, so for our specialty, different specialties have different port placement. For our specialty, it's the robot is docked in between the legs in a lithotomy position, and the target anatomy is always the uterus, and this is the surgical workspace. So none of the ports should be within the surgical workspace. So it's a conventional, almost like a laparoscopic port placement. And then we should dock before the docking, before the robot docks into the ports, we should place the table. In some system, there are table motion, which helps the movement of the table during the surgery as well. So this is the assistant driving the console towards the patient. So this is the beauty of the robotics system. It has a 3D HD stereoscopic endoscope, and it is like autofocus, and it gives you HD vision. So these are the new ports, which are 8 mm ports, and it has a band. You can see this black band in the port, which is called the remote center. It stays within the muscle layer of the abdominal wall. So if it stays in the muscle layer, there is less injury to the nerve fibers. So post-operative pain is almost nil after the surgery is done. So this is how we are docking the cannula to the robotic arms. And these are the endorist instruments. You can see at the tip of the robotic instruments, there are endorists. And the advantages of this endorist is the 7 degrees of freedom. Okay, 7 degrees of motion which happens, and it allows 540 degrees of motion, which is never possible in a conventional laparoscopic surgery. Okay, so it is also safe because you have rubber guards in front of the instruments so that there is no lateral thermal damage. So these are the common advantages of any form of minimal invasive surgery. Patient has invisible scars, better access to the target anatomy because of the magnified vision. Tissue handling is much less pain, less blood loss. Patient goes back home very quickly and gets back to normal life. What are the additional advantages with this robotic platform? We all discussed 7 degrees of freedom, 3D high definition vision, depth perception is much better. There is autofocus, there is auto white balance technology. Patient has less post-operative pain because of that. I told you the ports, and then inbuilt energy device is there. There is tremor filtration. When the surgeons grow older, they are bound to have tremor. It is filtered by the robotic surgical system. There is a technology called Firefly technology. I'll come to that later in my video. And all the ports are 8 mm. So you can exchange instruments to any other port. You can change the endoscope as well during the course of surgery. So basically what it gives is called a precision surgery, right? So conditions where we use robotic surgery in gynecology, especially in gynecological malignancy, it is extensively used to treat endometrial cancer. Sometimes we use for early cervical cancer as well. There is controversy, I'll come to that. Simple hysterectomies for EIN and CIN. For early ovarian cancer, even in some cases of interval cytoreduction after neoadjuvant therapy. Benign cases we use extensively for endometriosis surgery. I have found amazing benefits in endometriosis. Hysterectomy for large fibroid uterus, for myomectomies, sacrocolpopexy for tubal reanastomosis. So lot of variety of options available. And what does the evidence say? So FDA approved the robotic system for gynecological operations in 2005. And in 2012, the Society of Gynae-Oncology, the SGO, they had said, as consensus opinion, that it is improved benefit with obese patient. They have expanded the usage to cervical and ovarian cancer. The learning curve, they said, is shorter and is improved the quality not only of the patients, but as well as the quality of life of the surgeons. But 2018, there was a trial published in NEGM called the LAC trial. It said minimal invasive radical hysterectomies had a lower survival rate compared to the open radical hysterectomies. It had created a lot of buzz. People have stopped doing minimal invasive surgery for cervical cancer. But the pitfall of this study is only 15.6% were robotic surgeries. Rest of all were laparoscopic surgeries. So there is another new trial called the ROC trial, which is in recruitment has started from March 2022, which is comparing head-on robotic radical hysterectomy versus open radical hysterectomy in cervical cancer. So I'll come to a video. Basically, this is a video of sentinel lymph node dissection for endometrial cancer. We have given a dye called indocyanin green at 3 o'clock and 9 o'clock position of the cervix. Sentinel node, we all know, is the first node of the lymphatic basin which is drained by the cancerous cell. So you can see the instruments, the dexterity of the instruments is moving very easily. The round ligament is coagulated with the bipolar. So on the left hand, we have the fenestrated bipolar. On the right hand, we have the monopolar curved scissors. The round ligament is cut, and the broad ligament is anterior fold, and the posterior fold is developed. And we are going into the retroperitoneal space, which is a favorite space of all oncosurgeons out here in my co-speaker panel. So my assistant is helping out with the suction and retracting the small bowel. Okay, so we are going into the space, the retroperitoneal space, and it is the paravesical space we call. So you can easily appreciate the movement of the instruments we call the chopstick movement. Such dexterity is not possible in laparoscopy. It's very easily done in a robotic surgical platform. So we are moving in and we are trying to identify the vital structures. So you can see the external iliac artery which is pulsating right there. We will try to identify the ureter medial to the external iliac artery and the internal iliac artery. And then we'll try to map the sentinel lymph node. So we have a technique, we have a light called infrared light with a Firefly technology, which will give you this sentinel lymph node. So you can easily see the sentinel lymph node has taken up the fluorescence, and you can see the lymphatic channels as well. Okay, so we are trying to dissect out the sentinel lymph node, and we will send this node for frozen section. So once the frozen section biopsy says the sentinel lymph node is negative, we generally omit the systematic lymphadenectomy, so preventing the patient from having the disadvantages, the side effects of systematic lymphadenectomy, like lymphedema, like lymphatic abscess, post-op infection. So these are prevented in this kind of sentinel lymph node dissection. That's the idea behind sentinel lymph node dissection. Okay, so we are just removing that node and will be sending for frozen section. So I'll continue the video in our discussion session. So next, what are the drawbacks of robotic surgery? Any good thing will have its own drawbacks. The main drawback is lack of tactile feedback. What you get in laparoscopy, you never get in robotic surgery. But believe me, after doing 100 cases, I can easily understand that what I'm catching. I can have that feel. So that was not there in the initial 5-10 cases. There is limited mobility of the patient intraoperatively. You can't ask your anesthesia colleague, keep the table up, get the table down. That is not possible. For housing 3 components, you need a big OR. It's an initial capital investment is quite high. And the limited life of the expensive robotic instruments. That's the biggest challenge what we face in a third world country. Running cost becomes very high because all the instruments have 10 uses. After 10 uses, it gets locked. You can't use that instrument. Okay, and surgeon training is very robust and expensive, and hence the younger the gynecologists and the surgeons do not get access to the robotic surgical system. So at the end of the day, it's always a team effort. This is my team who is just about to dock the robotic surgeon, the robot into the patient. And this is the robotic theater orientation. You can see that's me sitting in the console, and this is the my team near to the patient, and there's an extra monitor for the observers to observe. There is a monitor for the anesthesia as well. So thank you for your kind attention. It was a pleasure talking to all. I'll just play continue the video of lymphatic node dissection once we discuss with other speakers. Thank you.
Thank you, Dr. Basu, for your informative presentation. Now it's time to take comments from our chairperson, Dr. Sylvia Hussain.
Thank you, Nandita. Assalamu alaikum and very good morning to you all. It was really a brainstorming session. Our learned speaker, Dr. Sanjay Gandhi, clearly focused on recent updates of cervical cancer vaccination. Actually, for the elimination of cervical cancer, we all know that we have to vaccinate 90% of our adolescent girls between 9 to 14 years of age by 2030. And we are very hopeful that it will be included in our EPI schedule. And Dr. Aisha Siddiqa clearly said that actually 75% of our ovarian cancer came to us in advanced stage, as in early stage, signs symptoms are non-specific and most of our patients went to the gastroenterologist without any ultrasonographic evaluation. So in advanced stage, our challenge is whether we will go for the primary debulking surgery or neoadjuvant chemotherapy followed by interval debulking surgery, as surgery is the cornerstone of management, but residual tumor is the predictive factor. So she clearly stated when we can predict the suboptimal cytoreduction. And Dr. Shushmita said on GTN, it is a highly curable disease, but there are some challenge in management. There are some set criteria for the post-molar GTN and non-post-molar GTN. We should be cautious about when the GTN is diagnosed. We all should stage the patient and prognostic scoring should be done to choose appropriate chemotherapy regimen. Without this, we will fail to treat the patient. And thank you to all.
Now I am requesting Dr. Zakia Sultana for her comment.
Honorable advisors and learned audience, Assalamu alaikum. I will sum up the presentation of last two speakers regarding Dr. Jakanta's presentation. She talked about the endometrial thickness is the predictor of endometrial carcinoma. Yes, obviously it is, and it can be done reliably by transvaginal sonography. And by seeing the endometrial thickness, we can further go for DNC or fractional curettage, followed by histopathological examination and final confirmation of endometrial carcinoma. She tells us about the cutoff value of endometrial thickness in pre and post-menopausal women, and it is 3 to 10 millimeter and 3 to 5 millimeter respectively. And by seeing the endometrial thickness, we can go for further management of endometrial carcinoma. Thank you, Dr. Jakanta. Your presentation was flawless. And lastly, I will talk about Dr. Kastab Basu's presentation, who tells us about the scope of robotic surgery in gynecological malignancy. And we are blessed to have him here, and his presentation was so nice, and we came to know that this fine and modern technique of robotic surgery can be easily impacted to our daily practice for the precision of surgery with some additional benefits of minimal invasive surgery. It has some few drawbacks, but it is negligible. And I am very thankful to him to bring up such updated presentation here. And I am thankful to the organizer to give me the scope to chair this session. And hopefully these types of programs will be continued thoroughly as well. Thank you.
Now, I am requesting our Honourable Advisor, Dr. Sabira Khatun Madam, to give her words of wisdom regarding the session.
Thank you, Dr. Nandita, for calling me. আমি এখানে সেই বলছি বিকজ আমি ওখান থেকে ভালো দেখাতে পারবো না এবং আমি I'm talking in English because we have two foreign speakers in our audiences. Honorable chairpersons of this oncology session of First International Young Gynecologist Conference 2022. Dr. Sylvia, come here please. Dr. Sylvia and Dr. Zakia Sultana. Both of them are the very young, most shining young star in the field of gynecology of Bangladesh. I should congratulate their performance. And as the chairpersons of this session, they have done outstanding comments about the speakers. And I hope their comments are very true and very valuable. Again, I would like to congratulate these two chairpersons. Now, next, the respected advisors of this session, Professor Ashraful Nisa, Professor Rehana Parveen, Professor Shirin Akhtar Begum, Professor Fauzia Hussain, and Professor Jannatul Firdaus. All of them are the big shots in the field of gynecological oncology of Bangladesh. At present, we have 38 gyneco-oncologists bearing FCPS degree in gyneco-oncology, and we have also one gyneco-oncologist bearing MS degree. And I think every credit goes to these big shots in this field, and the success of this program is also due to their valuable opinion. I want to mention only about the name of Professor Shahana Parveen. She is a good coordinator. She has coordinated with all the speakers, advisors, and all the persons working for this session. Then Dr. Nandita, her communication skill is very high. She has communicated with everybody very nicely. Then rapporteur and house supervisors are also very efficient, I should say. Now regarding the speakers, I am very much overwhelmed and satisfied with the presentations of all the speakers. Thanks to all of the speakers for their unparalleled performance. Regarding the topics, vaccine, it has become an emergency to introduce the vaccine for all the targeted girls of Bangladesh. Now, second topic on advanced epithelial ovarian cancer. It is very challenging for both the big shots sitting in front of me and the young stars sitting on the dais to learn the extensive procedures for youth. Third topic is GTN. We are going to start the clinical trial on the prophylactic chemotherapy for high-risk molar pregnancy. I hope the result of this trial will reduce the incidence of GTN in our country. Fourth topic, endometrial thickness. First investigation on the endometrial thickness was done in 1990. I did not go details. The last of all, the robotic surgery by Basu, Dr. Basu is very impressive. And first series of robotic surgery was presented in 2002. And most important thing, difference in laparoscopy and robotic surgery is that the control is in the hand of a surgeon in robotic surgery, but control is in the instrument in case of laparoscopic surgery. Thank you all for your patience hearing.
Thank you, madam. We are at the end of the session. If you have any question, you may ask our speakers during lunch break. Now, I am requesting our rapporteur to give the formal vote of thanks. Thank you.
Thank you, our legendary advisors. Thanks to our chairpersons and moderator. My thanks to all brilliant speakers to deliver their excellent speech. Now I am requesting our advisor madams and coordinator to come to the dais and take a photo shoot.
So, so long the photo session goes on, I think we need to do an exercise. The young and old together. Because we have forgotten how to clap, how to encourage the young ones. So not like that, with me. Stop, please. So, 1, 2, and 3. Louder, please. Yeah, that should be rang after each speaker. Thank you so much.
No, intro, first intro. No. Hey.
Ladies and gentlemen, participants from home and abroad, Assalamu alaikum and good day to you all. I'm Dr. Fatima Jannat, currently working as consultant Fuad Al Khatib Hospital, Cox's Bazar. Welcoming you all to the first International Young Gynaecologist Scientific Conference 2022 organized by OGSB. Our session is Safe Labor, Reappraisal of Outcome, and it's very important for our national perspective. It's my pleasure to hand over the microphone to our moderator, Dr. Umme Tania Nasrin, currently working in Fetal-Maternal Medicine Unit of Dhaka Medical College Hospital, to run this whole session. Thank you.
Assalamu alaikum. Thanks, Dr. Fatima Jannat, for introducing me. I am so much honored and overwhelmed to conduct the whole session. And this is the fourth session. This is the fourth session of our first Young International Scientific Conference. In this session, we have two interesting keynote presentations from two our internationally renowned personalities, Professor Farhana Dewan, President-elect OGSB, and Professor Thomas F. Berg, who is currently working as professor of Harvard Medical School, and then a exciting panel discussion. This session will be chaired by Dr. Meem Shahrin, who is now working in Fetal-Maternal Medicine Unit, BSMMU, and Dr. Sangjukta Chaudhuri, Fellow of Fetal-Maternal Medicine. And we are sorry for our inconvenience. Slide change হচ্ছে না? And our hall supervisor is Dr. Pushpita Sharmin. We are very happy to say that in this session, we have senior advisors who helped us a lot for whole this session. Professor Ifat Ara is EC member OGSB, Professor Shamim Fatima Nargis, former Professor Sir Solimullah Medical College, Professor Shahanara Chaudhuri, retired head of the Department of Sen Gynae, Chittagong Medical College, Professor Fatima Ashraf, retired head of the Department of Sen Gynae, Shohid Sohrawardi Medical College, and Professor Shahi Farjana Tasnim, Professor Rangpur Medical College. Now, I am requesting Dr. Pushpita Sharmin to have their seat. Thank you. Now, ladies and gentlemen, this is our exciting keynote presentation. Our first keynote speaker, Professor Fahana Dewan, senior OBGYN specialist of our country. She has been working so many years for different aspects of safe labor and has vast experience in this field. Now, I over to Professor Farhana Dewan.
Yes. Respected chairs, advisors, and dear audience, good morning. I am really honored to be able to present in this esteemed platform, and I would like to thank our president of OGSB, Professor Ferdowsi Begum, for giving me this opportunity. Actually, safe labor has to be safe, and we are talking about safe labor even now after years of delivering women. At the outset, I would like to acknowledge Sir Sabaratram Arun Kumaran for his help in helping me in preparing these slides. During my presentation, I'll talk, after introductory words, I'll go into the strategies to ensure safe labor, and then we will talk in elaborate. Actually, giving birth is a life-changing event, and it's necessary to ensure mother and newborn have the safe outcome possible. And it's well documented that safe delivery can minimize the complications if it is done safely, and the skilled health service provider is needed. Most of the maternal deaths, stillbirths, and the neonatal deaths could be avoided through the delivery of the timely interventions if it is done properly. And the role of the skilled birth attendant is very important. Now, dear audience, I'll go directly into the strategies to ensure safe childbirth. Among the strategies, we'll talk about the WHO Safe Childbirth Checklist and the Interpartum Care Bundle in the healthcare. So, WHO Safe Childbirth Checklist is a checklist which has been endorsed by WHO, and here there are 4 points which we need to know when the woman is admitted, when she pushes, when she's delivered, and when she goes off. So it is an essential practice that it should be performed in every facility, and these are the 4 checklists where we can see whether the woman has got, whether the blood pressure is normal, whether she needs antibiotic, whether she needs referral, whether she needs antihypertensive, and this is when just before she pushes or before cesarean. This is the second checklist. This is the third one. And after that, we have the 4th checklist just before she is discharged, whether she needs anything else or not. And WHO has come up also with the implementation guide, and there are also different countries, they have also adapted it and used it in their own. Now, coming to the care bundle in the healthcare. So, we'll talk about the respectful maternity care, care bundle 1, that's a birth companion, care bundle 2, interpartum care guide, care bundle 3 is the intermittent auscultation, and care bundle 4 is the active neonatal resuscitation. We know what is a bundle, and Thomas Burke is the creator of this concept of bundle. He's here only. So it is a collection of things or quality tied up, and they collectively, when performed, improve the quality of care. And it should be done in every patient, every time together. It is also used as an audit tool. Respectful maternity care refers to the care organized for and provided for all women in a manner that maintains their dignity, privacy, and confidentiality, and ensures freedom from harm. And these are the 7 components of the respectful maternity care. One of our panelists will be talking on it, so I'm not going to go into the detail. And there is a quality of care framework which talks about the provision of care and the experience of it. We never think what the woman feels. That is the experience of care. And when we talk about these, it then covers the respectful maternity care. Now coming to the birth companion, a companion of choice is recommended for all women throughout labor and childbirth. And it may be any person whom we decide to be the companion. And WHO has come up with the evidence to action brief in 2020, where the companion choice is, they have explained about it, and they say that it improves the quality of care. So they have some more recommendations coming up. Continuous support during labor may improve the outcome for women, increases spontaneous vaginal birth, reduces the duration of labor, may reduce the incidence of cesarean section, instrumental vaginal delivery, and there is no evidence of harm of continuous support. Now we are coming to the care bundle 2, that is the interpartum care guide. This is the heart of the management of labor. This is the heart of keeping labor safe, because we will be monitoring the woman from the beginning to the end until she delivers. So we are now at a transition period where in our country we are using the partograph. Some of us have started doing the labor care guide, but not really. So we will be monitoring the woman. So when and we all established that labor, it is after 5 centimeter dilatation, we'll call the active phase. Why? Because sufficient time is given for full dilatation, thus reducing the instance of oxytocin use, because too much and uncontrolled use of oxytocin infusion may cause injury to the fetus. And if we have to go for cesarean, that may result in unsafe outcome. So the first stage, latent phase and active phase has been defined as such. And the duration of the first stage is 12 hours in primary gravida and 10 hours in the other gravity. Second stage also varies according to whether the epidural is given or not. So there will be a delay in the labor ward admission. And this is the WHO partograph. This is the first WHO partograph we came up with after studies were done with 35,000 women. And then, but still there is a low universal application because it's not used. And this is the first WHO partograph by Arun Kumaran and his group, where you can see that initially there was a latent phase which has now been removed. And then the labor curve is Zhang came up in 2010 with the labor care, he has proved that it is the labor care will be with the 5 centimeter dilatation. The importance of labor analgesia is very important, where epidural analgesia is recommended. There are non-pharmacological methods of pain relief as well. And this is the WHO BOLD project, which talk about the development of the simplified effective labor monitoring to action for better outcome in labor difficulty. And these are the components: respectful care, communication, labor companion, and actionable information. And there was a systematic review which talks about what is the women want, and they want a positive childbirth experience. So this is a labor care guide described in 8 sections. 1 and 2, identification and supportive care. 3 and 4, the baby and the mother. 5 is progress of labor. And these are the other components of the labor care guide. The last one, second last, is the intelligent intermittent auscultation. So what we do when we auscultate the fetal heart rate, we look for acceleration. and we look for deceleration. So first of all, we see the baseline fetal heart rate on admission. Then we listen to the movement. When the mother feels the movement, we see whether there is acceleration or not. This proves that the somatic system is all right. Then we hear for deceleration just at the end of a contraction. And these are done by digital display and also by the Doppler. So this is the last care bundle, that is the active neonatal resuscitation, which will talk about the early breastfeeding and the kangaroo mother care. So dear audience, I'm end of my presentation. I would like to finish by saying that it is necessary and essential to ensure the mother and newborn have the safest care. More than 1/3 maternal death, half stillbirth and quarter neonatal death result from complication during labor. So we have to improve the quality of care around the time of birth. Thank you very much for patient hearing.
Thank you, Professor Farhana Dewan, for your nice, elaborative, updated, and very informative presentation. We have learned a lot from Specially Labor Care Guide, which is a new concept for us. So, ladies and gentlemen, a big clap for respected Madam Professor Farhana Dewan. Thanks. Now, we are very happy to say that today, along with us, we have an internationally renowned personality, Professor Thomas F. Burke, the inventor of PPH bundle approach. He has been acting more than 25 years in the concept of maternal survival and PPH. So, I would like to offer now Professor Thomas F. Burke.
Thank you very much. And first of all, I wanted to thank my senior colleagues who are really extraordinary as I've gotten to know them over the years. And it's such a privilege to be here with you. I'm grateful for the opportunity to speak with you. I decided with 10 minutes that I wanted to talk directly to you instead of putting slides up. And I thought about what do I want to say in 10 minutes. And to begin with, I noticed that it says young gynecologist. So I asked, what does that mean? And I was told it means under age 40. Well, I thought, well, then 21 years ago, I went over age 40. So perhaps I shouldn't have been invited, but I think I have a few people that are here with me my age too. So it's really a privilege to be here. Thank you. And I want to start with a couple of questions because, first of all of you in this room, all of you have studied hard, have dedicated your life. And when I was asked, can I say a few words about safe labor, I thought to myself, well, I've been working in the realm of postpartum hemorrhage and maternal emergencies for a few decades, but what can I say in 10 minutes? And I thought to myself, clearly, each of those interventions that you all know well, whether it be prevention, the importance of family planning, the importance of preparing yourselves with understanding how to technically take care of a mom who is suddenly hemorrhaging or who is beginning to seize or all of that. Obviously study that and know that well. But let's think about it in a bigger picture. First of all, I want to ask a few questions. How many of you have a daughter? Raise your hand, please. Excellent. How many of you have a sister? Keep your hands up. How many of you have a sister? I want to see if a few. Okay. How many of you have a mother? Wow. That means we're all in the same family, all of us. We are joined. We all have mothers. We all have sisters. Many of us have daughters. So I think this is really important to think of. All of you, all of us have something about what it means for safe labor in our hearts. Deeply in our hearts. And it's our job in our careers to keep those deeply in our hearts. If we do that and we pull that out, pull that love out, and bring that to our work and not forget that. I tell this to young medical students and young doctors at Harvard a few times every week. I say the most important thing is the love that you have, that you bring here when you come to Harvard. Don't forget that when you're 50. Don't forget it when you're 40, but don't forget it when you're 60, because it goes away in so many people. And then our ability to take good care goes away as well. So remember that love. So I saw leadership, and that's what I would like to spend a few minutes and talk about. I've been lucky enough the last few days to get very little sleep, but travel around Bangladesh and meet a number of people in really the other side of the table of safe labor, and that is the pediatricians and those who are taking care of the babies, the neonatologists. And I've asked the question, what's your number one problem? What is the biggest problem? And you know what I heard? I heard accountability, motivation, incentives to provide quality care, and incentive. There isn't any financial incentive, there isn't any reward, there isn't anything in place that makes people behave in a way that they provide better care tomorrow than they did today. So what is that going to require? That requires exactly what this is about. That requires leadership. In order for us to provide better care tomorrow than we do today, we need leaders. And all of you are young, full of energy, except those amazing leaders in front of me. They've already figured this out. But you need to figure it out. What does leadership mean to you? It means more than just being technically competent with that mama that's in front of you that you want to have bring about a beautiful baby in this world and have safe labor. It means that you start thinking about what will it take that we don't even get into an emergency situation? What does it take for me to care about not just the mother in front of me, but maybe the mother that is in a different facility, in a lower level facility, and I have expertise as a well-educated doctor, but where that mother is laboring, they don't have that expertise. If she's in our heart, if we're going to be true to why we went into medicine and bring that love, it's not just mama in front of me, but it's also mama that's in the waiting room. It's mama that delivered a few hours ago and needs to be monitored and cared about, and it's the mother at another facility. So what does that mean practically? What are you going to do as a leader? As a leader, you should go out into your community. Be a leader. Go with love. Go with a smile. Encourage and teach others. Take your knowledge and teach others that didn't have the good fortune to have quite as much knowledge and skill as you do, and you become an extension. Make them better. That's the whole purpose of this postpartum hemorrhage emergency care package that some of you have heard about. It's really about, let's understand how we can connect with our community, hub and spoke type of fashion, so that mothers are getting good quality care everywhere. That's the way we're going to change our health system. We're going to change our health system by being able to bring about quality care through our own leadership. And what does leadership mean? It means that you think about ways to lead. Some of the leaders at the front here, I've just been marveled by Professor Begum. I don't think she's ever slept, so as long as I've known her now, and what she does, and others that are here, your teachers. And it's not because they get paid a bunch. It's not because somebody's giving them lots of awards. It's because they've remembered what this is all about. And so that means that instead of sitting back at a meeting and listening and letting everybody speak and then getting up and leaving, it means that you sit forward and think about what you can contribute. It means that when someone needs something from you, you don't immediately think of how much money you can make, which sometimes erodes what we do. It means that we think about how can we bring what we came into medicine for, the privilege of being with a mother when she's in her most vulnerable time of life. How can we be committed to that with the mother in front of us and on a broader scale within our community? It means, there are all sorts of opportunities. There are endless opportunities, and there's endless need. You can get involved with advocacy. You can get involved with community outreach. You can get involved with policy and political change. You can get involved with an endless number of ways of contributing. With the postpartum hemorrhage emergency care package that some of you know and hopefully more of you will get to know, there are a number of different components, which is building a team for emergency care, but prevention is paramount. Early identification of a woman who's in trouble. What does that mean? That means you care, and that means people are paying attention to a mother in the community, a mother in the waiting room, so that she's identified early if she's in trouble. It means when you do understand that there's trouble, that there's an alarm, and everybody is responding. It's not just, oh, somebody else is going to take care of that. And it's we all care. We all bring love into it. Okay? And then now mother is taken care of, or mother delivers. And one of the greatest challenges in the stories that I hear in countries all over the planet all the time, and that I'm sure all of you have heard too, is, oh my goodness, you know, she had a baby, everybody was happy, and then 2 hours later she's found near dead because people forgot about her. People didn't care enough to change our system that we actually are meticulous in providing the quality of care that's necessary. So I would ask all of you to think about the best way that you in your career, you're all only under 40, fantastic, that in your career, think about how you can be a leader in the community. Think of how you can follow in the footsteps of these giants who have paved the way, and think about how you can impact maternal health beyond all the skills that you've learned that's just focused on the mother in front of you. We learn as doctors to use almost a microscope in how we care. I would ask you now to look much more broadly into your waiting rooms, into your community, into your health systems and your facilities, and how can you spread your commitment and love for mothers to others so that we can all have healthier labor for our mothers. Thank you.
Thank you, Professor Thomas F. Berg, for your encouraging words to our young gynecologists. And this day is so exciting for all of our young gynecologists because Sir is physically present with us, and this is a big issue for us. So a big clap and also 3 clap for our respected Sir, and it is a really honor for us. Now, this is the time for our exciting panel discussion, and I would like to call upon our first panelist, Dr. Bappi Das. She will talk how preconceptional counseling ensuring safe pregnancy outcome. Dr. Bappi Das.
Thank you, Dr. Tania, for giving me the opportunity regarding putting some comment about pre-pregnancy counseling. Pre-pregnancy counseling is a cornerstone in modern obstetric practice nowadays. It is an appointment of a couple with the healthcare provider planning for pregnancy. Pregnancy is a long journey, though it is a physiological process, but any time it may turn into pathology if we do not take proper care. So our aim is to achieve a good health before pregnancy. Usually we follow the steps during pre-pregnancy counseling are a thorough history taking, physical assessment, some lab investigation, risk scoring, offering some health education, and then medical and psychological interventions where needed, vaccination and counseling regarding the whole journey of pregnancy and childbirth. We want to prevent unplanned pregnancy. We want to prevent birth defect. We want to reduce preterm birth and fetal dysmaturity. We want to prevent poor pregnancy outcome and its recurrence, promote healthy behavior and reduce risky behavior. Overall, promote family planning. Some recommendations according to SEOG 2019, screening of infection like STD, chronic UTI or any other infection, immunization against hepatitis B virus, rubella, and in the recent era against COVID-19, any chance of chromosomal or genetic disorder by assessing age and family history, assessment of BMI, anemia, dietary habit, and any other comorbidities and correction, aware about possible toxins and teratogenic exposure to the couple, identify any psychological disturbances along with domestic violence, offering some lab tests like complete blood count, blood grouping and RH typing, OGTT, thyroid function test, urine routine microscopic examination, and cervical cytology. And tablet folic acid should be given because it is the drug which has a large role in preventing neural tube defect, and it should be given. So, we the obstetrician and gynecologist have a prime opportunity to promote maternal, fetal and neonatal outcome by pre-pregnancy counseling, as it provides excellent chance to counsel patients about adopting healthy lifestyle and reducing risky behavior. So, it should be for all. Thank you for patience hearing.
Thank you, Dr. Bappi Dash, for your excellent word on importance of preconceptional counseling. Now, I would like to call our next panelist, Dr. Farhana Islam. She will give her valuable opinion regarding what is the importance of antenatal exercise. Dr. Farhana Islam.
Assalamu alaikum and good morning, everyone. Thank you, Dr. Tanya, to give me the opportunity to say about the importance of antenatal exercise. Every pregnant lady during her pregnancy wishes for a safe and healthy delivery. For this, expectant mothers are suggested to do antenatal exercise. It includes low-impact aerobic exercise and stretching exercise, and is aimed at improving the physical and psychological well-being of an expectant mothers for labor and preventing pregnancy-induced pathologies by various physical means. Now, what are the importance? Regular antenatal exercise improves circulation for mother and baby, helps in control weight gain, reduces aches and pains of pregnancy such as backache, leg cramps. It also helps in reduction in mild ailments of pregnancy like morning sickness, anxiety, sleeplessness, and constipation. ACOG recommended that low impact or moderate exercise for 30 minutes on most days of the week during pregnancy. According to ACG recommendation, it improves muscle strength, core stability, muscle length and flexibility, and posture. It enhances relaxation and prepares for physical demands of labor. Nowadays, we promote vaginal birth. In regular antenatal exercise, there is a more incidence of vaginal delivery and decrease the incidence of cesarean section. It also reduces the incidence of gestational hypertensive disorder, gestational diabetes mellitus, preterm birth, and low birth weight baby. Regular exercise also improves postpartum recovery time, maintain physical fitness, and bladder control. Here, the picture shows some procedure of antenatal exercise. We can implement this antenatal exercise at outdoor in antenatal clinic at the time when the patients are waiting. We can take the help of a physiotherapist who will teach them about the procedure of exercise, or at least run a video about the procedure of exercise. So, by application of regular antenatal exercise, we can increase the rate of vaginal birth. Thank you.
Thank you, Dr. Farhana Islam, for your nice information about importance of antenatal exercise. We know that is a quite important issue in current perspective. We know that birth planning is quite important to ensure safe birth and also to reduce stillbirth. So our panelist, Dr. Sharmin Akhtar, will focus on preparedness during antenatal care to reduce stillbirth. Dr. Sharmin Akhtar.
Thank you, Dr. Tanya. Honorable chairs and respected dignitaries, Assalamu alaikum and very good morning. I am really honored to be a panelist in this session. Now, I will talk about more important issue, that is preparedness during antenatal care to reduce stillbirth. Stillbirth rate is a sensitive indicator of quality of care in pregnancy and childbirth as well as a health system of a country. Globally, there are nearly 2 million stillbirths in every year, about 1 each 16 seconds. And among this all stillbirth, about more above 40% occur during childbirth, but these loss should be should be minimized with quality and respectful care during delivery. And now stillbirth rate in Bangladesh about 28 per 1,000. We know stillbirth may occur during antepartum or intrapartum. Intrapartum, that is fresh stillbirth. Dear audience, let's look to strategies to reduce stillbirth during antepartum period to raise awareness among pregnant women and their family members by advocacy. To ensure WHO recommended all antenatal visit, and quality antenatal care is very important to reduce stillbirth, but in our country it is around 30%, so we should focus on this issue. Meticulous antenatal screening of high-risk mother and prenatal genetic counseling, screening and diagnosis to improve maternal health by nutritious diet and some lifestyle modification. Antepartum fetal surveillance by thorough investigation, both clinical, laboratory, and radiological. Treat and refer high-risk cases accordingly, and do a proper comprehensive birth planning for safe delivery. Then, during interpartum care, close monitoring of labor with partograph or labor care guideline, ensuring presence of skilled birth attendants, but in our country only 42%. Clean birth practice, identification and complication, and timely referral, and availability of 24-hour 7-day services, including both comprehensive and basic emergency obstetric care, and finally established a sound surveillance system. So we can conclude it by saying that hence quality antenatal care and strict vigilance during delivery is the mandate of every obstetrician, nurses, and midwife who taking care of pregnant women to reduce stillbirth. Thank you very much.
Thanks a lot, Dr. Sharmin Akhtar, for your nice discussion on birth planning. We know that rising trend of cesarean section is an overburden in current perspective of our country. And the key approach to reduce it is the promotion of vaginal birth. Our next panelist, Dr. Sabrina Parveen, will give her information that what are the strategies to promote vaginal birth.
Assalamu alaikum. Thank you, Dr. Tania, for giving me the opportunity. As we are concerned that cesarean section rate is increasing day by day, so promotion of vaginal birth is very much important to reduce cesarean deliveries. So what are the strategies to promote vaginal birth? The strategies to promote vaginal birth are counseling during antenatal period to develop awareness of benefit of vaginal delivery and to educate the mother about the physiology of pregnancy and labor. Wait up to 41 weeks of pregnancy. It increases the chance of spontaneous vaginal birth, and spontaneous patient can go into spontaneous labor. Respectful maternity care is a universal human right and a new way of taking care of birthing women, where they are treated with dignity, confidentiality, and sympathy so that she feel confident. Risk screening in antenatal period. Antenatal screening of high-risk pregnancies, treat and refer them accordingly. It has promising effect in vaginal birth. Presence of birth companion. A companion of choice is recommended for all women throughout labor and childbirth for improved quality of care. Supportive care during labor and delivery. It increases spontaneous vaginal birth, reduces the duration of labor, and ultimately necessity of any sort of analgesia. Judicious use of induction and augmentation of labor reduces the rate of cesarean delivery and perinatal mortality. Monitoring of labor with partograph. Introduction of partograph in the management of the labor has reduced the incidence of prolonged labor and cesarean rate. So we should strictly follow to maintain partograph up to the end. Monitoring of fetal well-being by intermittent auscultation of fetal heart sound with fetal stethoscope, then biophysical profile, fetal Doppler, and the CTG. Labor is a long process, and we should be very much vigilant for monitoring the fetal well-being. Robson 10 group classification system. This system classifies all the women up to one of the 10 groups to analyze all the labor events and outcomes. Provision of vaginal birth after cesarean section. Assisted vaginal delivery, training in and ongoing maintenance of practical skills to operative vaginal delivery should be encouraged for promotion of vaginal birth. We know cesarean section is done in most cases of the breech presentation. So if external cephalic version is done in nulliparous breech and conduction of vaginal breech delivery are done, then we can promote vaginal delivery. So dear audience, these are the promising options which can help to promote vaginal birth. Thank you very much.
Thank you, Dr. Sabrina Parveen, for your nice presentation. We have learned a lot of strategies to reduce cesarean section by promotion of vaginal birth, and hopefully we are young gynecologists and all we will practice in our hospital or private practice to promote vaginal birth. Now, our next panelist, Dr. Shohana Ashkari, will focus on a very important and burning issue of current perspective in our country, that is respectful maternity care, right of birthing women.
Assalamu alaikum, learning audience. Thank you, Dr. Nasrin Tania, for giving the floor. As our keynote speaker, Professor Farna Dewan Madam, already mentioned about the respect for maternity care, I make some point on it. Respect for maternity care is a right of birthing women. It is universal human right of every childbearing woman in every health system around the world. Provision of respect for maternity care is in accordance with human right-based approach to reduce maternal mortality and morbidity. And so, what is respect for maternity care? It refers to care organized for and provided to all women in the manner that maintain their dignity, privacy, and confidentiality, and ensure freedom from any harm and mistreatment, and enable informed choice and continuous support during labor and childbirth. According to FIGO 2018, October, RMC have 7 components: avoidance, mistreatment and harm, privacy and confidentiality, dignity, information and informed consent, family and community support, quality environment and resources, and effective communication. And every birthing woman have 7 rights, and there are 7 types of abuse and disrespect. Women cannot be abused either physically or verbally. They should free from any harm and ill treatment. Their confidentiality and privacy should be considered, and their treatment should be free from any discrimination, and their liberty and autonomy should be also considered. So why RMC is important? The National Human Rights Commission received 122 complaints related to obstetric violence during 2009 to 12 in Mexico. 4 out of 10 women experienced violence and episiotomy without consent, and it happened to 1.6 million laboring women in Italy. 62% women who experienced episiotomy were not asked for any consent in Hungary. So, respect for maternity care is not only a crucial component of quality care, it's a human right. RMC could improve women's experience of labor and childbirth and address the health inequalities. So, how respect for maternity care can be promoted? Several strategies and interventions are addressed for promotion of RMC, like strengthening training, implementing quality improvement approaches, developing clinical guidelines and protocols, and implementing community activities like campaign, strengthening the local laws and regulation. Finally, advocacy, including initiatives and client right charters, can be implemented. Here are some pictures of respect for maternity care supported by UNFPA, the right for information and privacy, the right to choose a birth companion, having food and drink during labor, and right to liberty of movement during labor, and right to favorable birth position during childbirth, keeping the mother and baby together. So we should respect for belief and culture. We don't need to share the same opinion as other, but we need to be respectful. Thank you.
Thank you, Dr. Shohana Ashkari, for your excellent presentation informative presentation on respectful maternity care, which is also very important for our day-to-day practice. We know that CTG is an electronic fetal monitoring for a birthing woman to detect fetal hypoxia,
but still now it is not widely practiced in most of the facilities, even tertiary center of our country. No, so Dr. Ruba Mahabin now give on focus what are the ways to overcome the obstacles of interpartum fetal monitoring.
Thank you, Dr. Tanya, for giving me the opportunity to tell something regarding the way forward to overcome the challenges of fetal monitoring. I am here as a panelist. Welcome you all to our presentation. Though electronic fetal monitoring is an important fetal monitoring tool in high-risk parturient, but not widely practiced in our country, even in tertiary level hospital, some practical steps should be taken for optimizing the utilization of electronic fetal monitoring in our country. For that purpose, we need some logistic support and skilled manpower. For logistic support, we need a good CTG machine with continuous power supply to maintain power to the device in the event of power loss while the machine is already used. Provision of dedicated room for the service with comfortable couch and lighting, CTG paper and a computer in place for record purpose. For dedicated manpower team or highly skilled team, we need a combined team with doctor and midwife. Team should know the indications of CTG in antepartum and interpartum period, position of the patient to prevent supine hypotension, interpretation of CTG, that is when it is reassuring, non-reassuring and pathological, and when to do action to prevent fetal hypoxia. Regular training and retraining is needed. More midwives should be involved. A written protocol should be maintained to avoid litigation. In high-risk cases, there is chance of fetal hypoxic injury. Tracing should be stored for several years. Monitoring team is needed for proper utilization. Monthly basis audit is needed. Though CTG is very sensitive to detect fetal hypoxia, but its specificity is low, and proper utilization can avoid many fetal deaths. Cardiotocography has well-documented limitations. A large number of randomized controlled trials have been documented comparing continuous CTG monitoring with intermittent auscultation as a screening method for fetal hypoxia showed only 50% reduction in neonatal seizure and no differences were found in the incidence of overall perinatal mortality and cerebral palsy. Thank you all.
Thanks, Dr. Ruba Mahbin. We have learned a lot how to overcome to ensure CTG in all facilities of our country. We know that obstetric hemorrhage is still now the leading cause of maternal mortality in our country. So, innovative approaches will play an important role to reduce this obstetric hemorrhage. As from our keynote presentation, Professor Farhana Dewan and Professor M. Thomas Berg already stated a lot, but now our panelist, Dr. Ismat Jahan, will elaborate details about PPH bundle approach.
Thank you, Dr. Tania Urmi, for giving me the opportunity. Respected chairpersons, learned audience from home and abroad, Assalamu alaikum. My topic is PPH emergency care using bundle approach. So, what is bundle? A number of things that have been tied or wrapped together. And we all know the proverb that is, many a little makes a miracle. So, related to this concept, a care bundle is a set of evidence-based interventions that includes package of care. When used together, it significantly improves the outcome. So, in bundle, there must be a trigger. For example, in PPH, bleeding is the trigger, and all the component elements of the bundles are completed unless it's contraindicated. So in PPH bundle, it has two components, clinical and non-clinical components. In clinical components, it has two bundles, first response bundle and refractory PPH interventions. So in first response bundle, it comprises uterine massage, IV fluids, uterotonics, tranexamic acid.
And there are 3 supportive measures, that is, treat the tears, empty the bladder, and empty uterus. So the first bundle trigger is the bleeding. Next comes to refractory PPH interventions. It comprises compression maneuver, bimanual and aortic compression, uterine balloon tamponade, and non-pneumatic anti-shock garments. So in previously, we only emphasize on clinical components, but nowadays, non-clinical part of the PPH management gaining more importance day by day. And it comprises respectful maternity care. In this, every woman should be managed in a friendly environment, and we should show every woman respect. Next, teamwork and communication. PPH should be managed like a football team. We should create an obstetric rapid response team in every hospital. When the bell rings for PPH, the ORTT team must be ready and playing their own roles. Leadership. For PPH management, we have to have a good leader. Facility readiness. We have to have 24/7 facility ready, like emergency medicine, essential drugs, and transport systems. Network integration. For this, we have to have a good network integration. Improving the quality of PPH and emergency care. For this, we have to track data and improving our situation of the bundles. So these are the complete bundles. And in conclusion, dear audience, in conclusion, I would like to say, by using all the components of the bundles, we can reach our goals in managing PPH. Thank you all for patient hearing. Thank you, Dr. Thomas, for previously informed us about the PPH bundle. Thank you very much.
Thank you, Dr. Ismat Jahan, for your excellent and very informative presentation on PPH bundle approach. And we are very happy that our respected keynote speakers, Professor Farhana Dewan and Professor Thomas F. Berg, has encouraged very much, and Sir is so happy to see her presentation. And so a big clap for Dr. Ismat Jahan. Ladies and gentlemen, now we are at the end of our panel discussion. Our last panelist, Dr. Irene Binte Sattar, will give comment on audit, an integral part to ensure safe labor.
Thank you, Dr. Tania, for giving me the floor. Respected chairperson, teachers, and dear audience, I will talk on the topic that is audit, an integral part to ensure safe labor. I think audit is an area of unpaid attention in our health services. So what is audit? Audit is the systematic and critical analysis of the quality of medical care. It provides a rational framework for quality improvement by systematically assessing clinical practices against accepted standards. That means when a case is managed clinically, whether it was done by following standard protocol or not. So there is a specific audit cycle which should be followed. Number 1, we have to define the standards. And then number 2, we have to measure the current practice, that what was done in managing the specific case, whether it was done by following the standard protocols or not. Number 3, we have to identify the gaps which should be changed. And then number 4, decide and implement action. And finally, review the standards. So what is the aim of audit? To identify and address the gaps, to develop recommendation and interventions that target modifiable deficiencies, to mitigate or eliminate health system faults and practices, and ultimately to achieve an uniform and standardized practice which are evidence-based. So what is the outcome of audit? That is, when a case is audited and modification is done, we can improve the quality of care by utilization of our services, that is, skilled birth attendant is ensured, respectful maternity care is included in labor care center, emergency obstetric care is incorporated, and standardization of evidence-based practice, and ultimately we can achieve to reduce maternal or perinatal mortality and morbidity. So, what is the role of audit in safe labor? Safe labor practice ensures that all deliveries are attended by the persons with right knowledge, skills, and equipments, and also provide postpartum care to mother and baby. There should be instruction from health department, specific learning session should be arranged, tracing of problems, and finally, submitting the result of feedback to the healthcare team. Interestingly, we can use Robson 10 group classification system for the audit of cesarean section rates. The factors that influence the success of audit program are the knowledge and participation of health worker in the community during audit process, the recommendation for the results of audit process, and implementation on the results of audit recommendation. So, we can conclude by saying that by performing audit program, we can able to reduce maternal mortality, improve the quality of services, and ensure safe labor practice. Thank you all.
Thanks, Dr. Irene Binte Sattar. And we are at the end of our very exciting panel discussion. And I am inviting all of our today's audience for clap, clap, and clap for our young gynecologists. They have done excellent work in their panel discussion. And it will be quite help in our future. Now, I am requesting our Honorable Chairperson, Dr. Meem Shahrin, to give her valuable comments regarding this session.
Thank you, Dr. Tania, and thanks to all the speakers and all the panelists for your beautiful discussion. And we know that the goal of this millennium is to reduce maternal mortality rate. And to ensure this, the first step is to ensure safe labor. And non-communicable diseases complicating pregnancy is a current day challenge, and this can be controlled and prevented by proper preconceptional counseling only. And antenatal exercise, though it's very common in developed countries, it's pretty uncommon in our country, specifically in the rural areas. And this is a very time-demanding need and needs promotion to the rural areas also. The burning question today is how to reduce the rate of C-section in our country, and for which strategies to promote vaginal birth should be implemented. Now, break the bias is the theme of Women's Day of this year. Hence comes the question of respectful maternity care, which should be her birthright. Now, over to Dr. Sanjukta Choudhury for continuation.
Thanks, Dr. Meem Shahrin. Dear audience, I am honored to get the opportunity to chair this prestigious session along with such international figure and my mentor. My co-chairperson, Dr. Meem, has already highlighted the key points of discussion of some of the panelists. Labor is a journey in which we have to take care of two prestigious lives. One is mother and another is unborn baby. And in regard to fetal life, interpartum fetal monitoring is very much important. One of my panelists highlighted this, and the important point is that meticulous management of interpartum fetal monitoring can prevent 50% neonatal seizure in 50% cases. Another important topic is postpartum hemorrhage is the major issue for maternal mortality. Establishment of PPH bundle care emergency response team at every healthcare facilities is a must, and it is a game changer for safe labor protocol. And last but not the least, audit is very much important, and it should be instituted to ensure accountability and to improve the healthcare facility services. Thanks all behalf of all on the Safe Labor team. Now over to Dr. Tania Nasrin.
Thanks, our Honorable Chairperson, Dr. Sanjukta Choudhury and Dr. Meem Shahrin for their nice, inspiring words. Now, I am requesting our Honorable Advisor, Professor Ifat Ara, to give her speech of wisdom regarding this session.
First of all, I want to thank the organizers for selecting me as the advisor. Labor is a big journey, and our panelist has done full justice to this journey. That is, starting from preconception counseling, exercise, intrapartum care, CTG, fetal surveillance, respectful maternity services, and last of all, audit. So I congratulate all the panelists for the excellent deliberation. I am really overjoyed, mesmerized, and highly impressed by their presentation. And about the two seasoned speakers. One is Professor Farhana Dewan. She has very correctly and very nicely mentioned all the checklist about safe delivery. And our next speaker, international, that is Dr. Thomas. He has rightly pointed out the need for leadership because this leadership is missing in our practice. We work from morning to night, but we don't go for leadership. So it is time to take the leadership, to come out from the hospital frontiers and go to the community and take the leadership and serve the community. Thank you, the organizers and everybody for giving me the chance. Thank you.
Madam, thanks, Professor Ifatara. Now, ladies and gentlemen, we are at the end of the session, and now I am requesting our rapporteur, Dr. Fatima Jannat, to deliver a formal vote of thanks. I am requesting all of our respected advisors to our dais for group picture. Thank you.
I deem a great honor and privilege to propose the vote of thanks on this memorable occasion. It's my pleasure to give thanks to respected and learned advisors, keynote speakers, honorable chairperson, panelists, and moderator. Their discussion enriched our knowledge enormously. I would also like to thank all the participants who joined with us today. Thank you.
Ladies and gentlemen, participants from home and abroad, good day to you all. I am Dr. Sanjida Sultana, currently working at Gynae and Obstetric Department, Shohid Sohrawardi Medical College and Hospital, welcoming you all at our first International Young Gynecologist Scientific Conference 2022 OGSB. Our session is high-risk session. That is very, very important for our national perspective. This is my honor to hand over the microphone to our moderator, Dr. Shafinaz Mehzabin, currently working at Fetal-Maternal Medicine Department of BSMMU, to conduct the whole session.
Thank you, Dr. Sanjida Sultana, for your kind introduction. Good evening, ladies and gentlemen. It's my honor to introduce our honorable advisors of this session. I would like to request our hall supervisor, Dr. Nusrat Mahzabin, to take our advisors on their seats. Our advisors are Professor Samina Chaudhuri, immediate past president, OGSB, Professor Firoza Begum, President Fetal-Maternal Medicine Society of Bangladesh and Vice President of OGSB, Professor Laila Parvin Banu, President Narayanganj Branch OGSB, Professor Nahareen Akhtar, Chairman Fetal-Maternal Medicine Department, BSMMU, Professor Shirin Farhat Siddiqa, Joint Secretary OGSB, Professor Munira Ferdowsi, Head of the Department Obstetric and Gynecology, Shohid Sohrawardi Medical College Hospital. Thanks for having your seats. I would like to request our two chairpersons, Dr. Sultana Parvin, Assistant Professor, Aichi Medical College Hospital,
and Dr. Tania Akbar, Assistant Professor, Enam Medical College Hospital, to have their chair. Learned audience, in this session, we have 5 speakers. The speakers are requested to complete their presentation in time. Our first speaker is Dr. Sanjay Gupta, former President, Foxy and Gypsy. He is from abroad and he will join live on our session. Dr. Sanjay Gupta, sir, can you hear us? Zoom link. We are waiting for live session with Dr. Sanjay Gupta. Sir, can you hear us? উনি ওয়েট করতেছে আচ্ছা দেন ভিডিওটা দেন
ম্যাম এখানে কোনো ভিডিও দেওয়া নেই এখানে কোনো যে আপনাদের হাইলাইট সেকশনে কোনো ভিডিও দেওয়া নেই মানে প্রেজেন্টেশন এটা হচ্ছে স্লাইড
না
প্রেজেন্টেশন ভিডিও দেওয়া নেই
প্রেজেন্টেশনটা জিনাতুল নাসরিন ম্যাডামের কাছে আছে ফোন হচ্ছে না
আচ্ছা কথা বলেন না ওটাতে যাব বলে দিন
আচ্ছা We are waiting for connection with him. Now, I'm requesting our next presenter, Dr. Sharmin Sultana, currently working at Sheikh Hasina National Institute of Burn and Plastic Surgery, for her presentation. Dr. Sharmin Sultana.
Respected teachers and dear audience, Assalamu alaikum and a very good evening to all of you. Welcome to my presentation, Placenta Accreta Spectrum, Early Detection Can Save Life. Today, I am going to discuss the placenta accreta spectrum with its diagnosis through risk factors and investigations with necessary antenatal preparations. We all know placenta accreta spectrum is a failure of normal decidualization due to the defect of the endometrial myometrial interface. Cesarean delivery, advanced maternal age, multiparity, placenta previa, smoking, frozen embryo transfer, Asherman syndrome, prior uterine surgeries or curatives are the risk factors for the development of placenta accreta spectrum. Well, the chances of development of PAS is 0.3% in the women with 1 previous cesarean delivery to 6.74% for the women with 5 or more cesarean section. There is association of PAS with previa and C-sections, and these are 3% for the nulliparous, 11, 40, 61, 67% respectively for the women with previous 1, 2, 3, 4 or more cesarean sections. Well, the diagnosis is crucial because the earlier the diagnosis, the more the chances of getting prepared antenatally to combat the possible complications. There are 2 modalities to diagnose the placenta accreta spectrum. Ultrasonography is the primary diagnostic modality. Another one is MRI. But the first trimester ultrasonogram scanning has lower sensitivity, so high index of clinical suspicion is necessary. For example, patient with previous C-section with ultrasound findings of low gestational sac implantation and anechoic lacunae indicates the caesarean scar ectopic with possible PAS. 80% of the accretas present with placenta previa in ultrasonography. Other grayscale findings are multiple vascular lacunae. The first 2 pictures are showing the loss of normal hypoechoic zone between the placenta and myometrium. decreased retroplacental myometrial thickness less than 1 millimeter, abnormalities of the uterine serosa bladder interface, and the fourth picture is showing the extension of the placenta into myometrium, serosa, or bladder. Color flow Doppler finding, the most common finding is turbulent lacunar blood flow, increased subplacental vascularity, gaps in the myometrial blood flow, and vessels breathing the placenta to the uterine margin. The timing of ultrasonogram is unclear, but there are some reasonable approaches like 18 to 20 weeks, 28 to 30 weeks, 32 to 34 weeks in asymptomatic women to assess previa resolution, placental location to optimizing timing of delivery, and possible bladder invasion. Another diagnostic modalities is MRI, though this is not the primary diagnostic modality, but it is of great importance for the difficult cases like posterior placenta previa, and when we need to assess the depth of invasion and lateral extension in suspected parcreta. The first picture is showing the dark interplacental bands on the T2 weighted imaging, and the second picture is showing the disruption of the zone between the uterus and the placenta. Though ultrasonography is the primary diagnostic modality, but the absence of ultrasound finding does not preclude a diagnosis of PAS. Thus, clinical risk factors remain equally important. The necessity for diagnosing the case earlier is for proper antenatal preparations with planned delivery. We need to maximize the preoperative hemoglobin values. We need to counsel the patient extensively regarding the chance of unscheduled delivery, risk of lower urinary tract damage, the need for blood transfusion, and cesarean hysterectomy. The location of delivery is of great importance because we need a specialist center with availability of blood products, adult and neonatal ICU by multidisciplinary team, and expertise in complex pelvic surgery. According to SEOG, 3407 to 3567 weeks of gestation is the preferred for scheduled cesarean section because this is the best balance between handling the neonatal complications and increased chance of maternal bleeding after 36 weeks of gestation. While the RCOG says 34.0 to 36 plus 6 weeks for the symptomatic women and 36.0 to 37.0 for uncomplicated women. Take-home messages are placenta accreta spectrum increases with the increased number of cesarean section, no definite etiology, there is no accurate way to predict its occurrence, so high index of suspicion and judicious use of radiology are needed. Extensive counseling, meticulous follow-up, and planned delivery should be ensured, and we need multidisciplinary team with level 3 or 4 center. Thank you very much.
Thanks, Dr. Sharmin, for your nice presentation. This is the time for our next speaker. I'm requesting Dr. Taslima Akhtar, currently working at Gynaecologist Department, DMCH, to deliver her presentation. Dr. Taslima.
Assalamu alaikum and good evening, all our respected teacher and respected audience. I'm Dr. Taslima Akhtar. My topic is optimum glycemic control of GDM patient, essential to improve maternal and fetal outcome. Mrs. X, 32 years, gravida 4, para 1, -1 IOD plus 2 abortion, no alive baby. Now she visited ANC clinic at her 30 weeks of pregnancy with symphysiofundal height, 34 centimeter, abdominal girth, 96 centimeter. Her blood sugar profile shows fasting blood sugar 5.9, 2 hours after 9.7, and hemoglobin A1C 6.6%. She and her family is concerned about the high blood sugar and the fetal outcome. This is a pregnancy complicated with GDM, and this condition is not desirable by the doctor or also for the patient. So, how to improve maternal and fetal outcome? First of all, we see the burden of the gestational diabetes mellitus. Diabetes in pregnancy, most common medical complication of pregnancy and increases in prevalence globally. Figure has shown that 1 in 6 live births occur to women with some form of hyperglycemia. There are different definition and diagnostic criteria of GDM, and glycemic target also different. According to ADA, target is fasting less than 5.3, 1 hour postprandial it is less than 7.8, and 2 hour postprandial it is less than 6.7. Why we need to maintain glycemic index of the patient of the GDM patient? Because minor degree of hyperglycemia have adverse effect on the mother and the fetus. Uncontrolled diabetes mellitus causes excess neonatal and maternal short-term and long-term comorbidity. Here is the complication of the short-term and long-term maternal and fetal complication. So, benefit of glycemic control. Different RCT has shown that improved perinatal outcome with glycemic control in GDM. Another trial also shown that combination of dietary modification and self-monitoring of the blood glucose to achieve optimum glycemia and reduce serious perinatal complication. There are different articles which have shown that benefit of glycemic control, and it has shown that there is reduction of preeclampsia, macrosomia and shoulder dystocia. Define intensity of glycemic control for women with gestational diabetes mellitus. It is the article that has shown that regarding strict glycemic control in place of conventional or liberal target. But Cochrane review mentioned that there is inadequate evidence to guide clinical practice in favor of strict glycemic control. There is recommendation about blood monitoring 4 times a day, once after fasting and again after each meal. And 1 hour post-meal value is better because it correlates with fetal insulin secretion and neonatal complication. To achieve good glycemic control, there are 3 domains we have to work on, that is medical nutrition therapy, exercise and pharmacotherapy. Medical nutrition therapy has some goal, that is normal blood glucose level, prevent ketosis, adequate weight gain, appropriate fetal growth and development. ACOG recommend that carbohydrate should be 33% to 40%, protein should be 20% and fat should be 40%, and all this meal will be divided in 3 meals and 3 snacks. This is the chart of the maternal weight gain in normal pregnancy, but there is recommendation that in case of GDM, this target should be lower. For lifestyle intervention, recommendation is that 30 minutes of moderate intensity aerobic exercise at least 5 days per week. Insulin is preferred first-line agent for GDM treatment, both by ADA and ACOG, and combination of long or intermediate acting and short acting insulin. There are different doses in different trimester. For long or intermediate acting insulin, traditionally we use NPH, but recently glargine and detemir is being used. In case of short acting, traditionally we use regular insulin, but recently Lispro and Aspart are being used. For oral anti-diabetic medication, that is different thought. ADA and ACOG has said that there is lack of safety data, but it can be a reasonable alternate approach if patient cannot afford or safely administer insulin. Their concern is it crosses placenta, unknown long-term effect. FIGO has shown that metformin can be used as a first-line agent in case patient is not controlled with lifestyle modification along with insulin. Glycemic control also related with obstetric management, because if GDM is controlled with only diet, then obstetric management is up to 40 weeks, 6 days. If it is controlled by medication, then delivery is recommended from 39 weeks. And if it is controlled with insulin, delivery should be at 38 weeks. Interpartum glycemic management is important, hourly glucose monitoring, and it should be between 4 to 7 milligram per liter. Postpartum follow-up at 4 to 12 weeks, and if normal, repeat 1 to 3 yearly. So take home message, good glycemic control essential for optimum maternal fetal outcome. Recommended target is there, regular monitoring 4 times daily, and medical nutrition therapy, exercise, pharmacotherapy is the key of the glycemic control, and most guidelines recommend insulin as the first line pharmacotherapy. And we have seen the scenario during the starting of my presentation. To achieve the good glycemic control, we have to follow this protocol so that we can ensure a good fetal and maternal outcome. Thank you.
Thanks, Dr. Taslima, for your brilliant presentation. Our next presenter is Dr. Hafiza Farzana, currently working at Fetal-Maternal Medicine Unit, Dhaka Medical College Hospital. I'm requesting to Dr. Hafiza to deliver her presentation.
Thank you, Dr. Shapinas, for giving me the floor. My dear audience and my respected teachers, Assalamu alaikum. Welcome you all to my presentation on recurrent pregnancy loss, recent updates in management. Recurrent pregnancy loss refers to 3 or more consecutive losses before 20 weeks of gestation or fetal weighing less than 500 grams. ASRM defines recurrent pregnancy loss in a different way as 2 or more failed clinical pregnancies, excluding ectopic, molar, and biochemical pregnancies. The couples who never had a live birth are classified as primary recurrent pregnancy loss, and who experience repetitive losses after a successful pregnancy are defined as secondary recurrent pregnancy loss. Better prognosis is evident in secondary recurrent pregnancy loss. This diagram showing the causes of recurrent pregnancy loss, where we see unexplained causes comprises of 40 to 50% of the causes, and genetic factors includes 2 to 5% of the causes. Other factors are genetic factors, autoimmune, endocrine, and infective causes. Investigations that are considered to diagnose chromosomal abnormalities, endocrine causes, anatomical causes like septate uterus are mainly important in case of first trimester loss, and tests for cervical incompetence, inherited thrombophilia, and infective causes are important in case of second trimester loss. Antiphospholipid antibody syndrome can cause pregnancy loss at any trimester. Now about the genetic factors, which are related with most of the repetitive first trimester pregnancy loss associated with advanced maternal age and embryonic pregnancies, and where there is a history of congenital abnormality or mentally retarded babies. Diagnosis of the chromosomal abnormalities. Numerical abnormalities like balanced or unbalanced translocation can be diagnosed. Structural abnormalities like balanced or unbalanced translocation can be diagnosed well by karyotyping, and the numerical abnormalities like aneuploidy can be diagnosed by non-invasive prenatal testing, and polyploidy, copy number variations can be diagnosed well by chromosomal microarray. And single gene disorders can be diagnosed by Sanger's sequencing, whole exome sequencing, whole genome sequencing, next generation sequencing as prenatal genetic diagnosis. Regarding karyotyping of the product of conceptus is recommended at third miscarriage. Parental karyotyping is only recommended only if the product of conceptus reveals unbalanced translocation. ASRM recommends all couples to have a chromosomal analysis during their initial evaluation, and all patients should have genetic ultrasound to see the soft markers of genetic disorder during early anomaly scan at 11 to 13 weeks. Now, non-invasive prenatal testing at 9 to 10 weeks, if evident for high risk for aneuploidy, we can go for amniocentesis or chorionic villus sampling to confirm the diagnosis. And the diagnosis is confirmed, then medical options should be discussed. Treatment of the genetic causes includes genetic counseling mainly, proper evaluation for the diagnosis, assisted reproductive technologies including prenatal genetic diagnosis, and use of donor oocyte or sperm. Immunological causes includes autoimmune causes and alloimmune causes. Autoimmune causes are antiphospholipid antibody syndrome and systemic lupus erythematosus. And alloimmune causes are those who are associated with abnormal maternal response to fetal and placental antigen. To diagnose antiphospholipid antibody syndrome, 2 positive tests of either lupus anticoagulant or anticardiolipin antibodies of medium or high titer at 12 weeks apart is necessary. And recommendation of treatment in recurrent pregnancy loss with antiphospholipid antibody syndrome, where there is a history of thrombotic event, therapeutic dose of low molecular weight heparin, that is 1 milligram per kg, 12 hourly throughout the pregnancy and 6 weeks postpartum is recommended. And where there is no history of thrombosis, low dose aspirin 75 to 100 milligrams starting before conception and continuing 6 weeks of postpartum, and prophylactic dose of low molecular weight heparin reduces the recurrent pregnancy loss significantly. Now about the immunotherapy. Progesterone is the nature's immunosuppressant and is used as empirical therapy in unexplained recurrent pregnancy loss. ASRM considered progesterone supplementation in patients who have had more than 3 or more consecutive miscarriages. Multiple investigators have attempted to modulate the immune response by using paternal WBC immunization, IVIG, donor seminal plasma vaginal suppositories, but none of them found effective. Regarding anatomical causes that are associated with recurrent pregnancy loss are well diagnosed by sonohysterography, hysterosalpingogram, hysteroscopy, ultrasound, and MRI. And the treatment, regarding treatment, hysteroscopy is the procedure of choice in case of septal excision and polypectomy, laparoscopy or laparotomy for myomectomy, and magnonal suture is given in cervical incompetence. The endocrine factors are mainly thyroid disorder, diabetes, luteal phase defect, polycystic ovary, and hyperprolactinemia. And treatment is luteal phase defect treated by progesterone, thyroid replacement in hypothyroidism, optimization of the HbA1c level, and correction of hyperglycemia. Regarding male factor, Y chromosome microdeletion in case of agiospermia can be diagnosed by DNA testing. The main cause of DNA damage is oxidative stress, and this seems to be exaggerated by smoking, obesity, and excessive exercise. Routine sperm DNA fragmentation indexing is not recommended by ASRM, but ESHRE states that it can be done in recurrent loss. Sperm DNA fragmentation can be identified by sperm chromatin structure assay, single cell gel electrophoresis, sperm chromatin dispersion test, and the treatment is mainly done by antioxidants. 50% of the recurrent pregnancy loss still remain unexplained. Prognosis is still good, more than 50% live birth without any intervention. And in conclusion, I want to say recurrent pregnancy loss is an emotionally traumatic situation similar to stillbirth or neonatal death. Recurrence suggests a persistent cause, which is not just a bad luck and must be identified and treated. A full workup can identify the treatable causes, at least 70% chance of having a normal pregnancy even after 3 consecutive loss. Regardless of the cause, a thorough follow-up with appropriate psychological support can help a couple to have a successful pregnancy. Thank you all.
Thanks, Dr. Hafiza, for your time-demanding presentation. Our next presenter is Dr. Rumaisa Taher Bushra, Assistant Professor, Shirajul Islam Medical College Hospital. I would like to request Dr. Rumaisa to deliver her presentation.
Assalamu alaikum. A very good afternoon to my respected teachers, my senior and junior colleagues. Welcome to my today's presentation. I am going to present an important topics about postpartum psychosis and its management. Postpartum psychosis, it is a severe mental illness with in form of mania, severe depression, or a mixed feature of both high and low mood. Delusion and hallucinations are also common. It is also associated with confusion and perplexity. It occurs shortly after childbirth, and it occurs in a dramatic onset. The incidence is about 1 in 1,000 deliveries. There are several symptoms in case of postpartum psychosis. The most common symptoms here are feeling of high, manic or top of the world, low mood and tearfulness, anxiety, irritability, rapid change in mood, confusion, restlessness, agitated, hallucination and delusion, feeling of paranoid, suspicious and tearfulness. Suicide is also common in case of postpartum psychosis. The differentials that may be confused with postpartum psychosis are the perinatal blue and the postpartum depression. We can differentiate them by the onset of the disease and also by the symptoms. In case of postpartum blue, it occurs within 1 week of postpartum and usually present with fluctuating labile mood with a tearfulness. In case of postpartum depression, it is insidious in onset, occur during pregnancy or within first 3 months of postpartum, usually present with depressed mood with prominent anxiety features. In postpartum psychosis, it is already mentioned before. The patients who have a higher risk for developing postpartum psychosis, those who have a bipolar disorder type 1, have a schizoaffective disorder, or having a postpartum psychosis in herself, or having a postpartum psychosis in her close relatives. Assessment of the patient should be conducted by a multidisciplinary approach, a thorough history, a physical examination and laboratory investigation, including to exclusion of the systemic diseases, the hormonal causes, and also the toxic substance misuse. To assess the suicidal and infanticidal ideas and delusion should be clearly defined and their content should be explored. The treatment is based on the severity and type of the symptoms. In case of acute psychotic episode, the patient should be hospitalized immediately with a close observation, supervised visit with her baby also. The medication we commonly used are the antipsychotic drug, which can reduce the manic and psychotic symptoms like delusion and hallucination. The drug commonly used are chlorpromazine and haloperidol, olanzapine, etc. The mood stabilizer we usually uses to stabilize the mood and prevent the symptom recurrences. The drugs are used lithium and the anti-epileptic drugs like chlorpromazine and lamotrigine. And the antidepressant drug which helps to ease the symptom of severe depression. The most common used drugs are tricyclic antidepressant and selective serotonin reuptake inhibitors. The electroconvulsive therapy, it is a well-tolerated and effective for severe psychosis where all other treatment options have been failed, or in case of life-threatening situations where suicidal and infanticidal ideas are very high. The psychotherapy, in form of cognitive behavior therapy, it is a very much effective in case of mild to moderate depression and also following recovery from acute episode of illness. This therapy can help to manage the problem by changing the way of thinking and behave under a therapist. Finally, education and counseling to the mother and her family is also very important. The supportive therapy, the patient should increase bonding with her baby, connect with the family member and spend a quality time, join a supportive group where she can contact with other people with same disorders, engage in exercise, mindfulness and getting sunlight, follow a sleep schedule properly, should take intake of nutritious food. The clinician should support the woman in their choice to breastfeed after clear discussion of the benefit and risk who are on psychotropic medication. Mother having selective serotonin reuptake inhibitor drugs like paroxetine and sertraline are considered to be safe during pregnancy. Those mothers who are taking lithium should be encouraged not to breastfeed her baby. If they decided to do so, the close monitoring of the baby should be necessary, including the checking of the serum lithium level, thyroid function and renal function test. Mother with anti-epileptic drug, these are not contraindicated in breastfeeding but should also assess the benefit and risk, should be discussed in detail. Some antipsychotic drugs like ozapine and doxepine which are contraindicated in breastfeeding due to their side effects. And finally, the take-home message, the women and high risk need to be identified in pregnancy with the appointed obstetrician, should be under urgent referral to a psychiatric unit for early recognition and treatment. And finally, counseling her family, husband, and for the present and her future pregnancies. Thank you all.
Thanks, Dr. Rumaisa, for your nice presentation. Learned audience, we are sorry we tried to connect with Dr. Sanjay Gupta. Now we can connect with him. I'm requesting Dr. Sanjay Gupta, former President Foxy and Gypsy, to deliver his presentation. Sir, can you hear me?
I can hear you now, and please allow me to share so I can start the presentation.
Thank you, sir.
Dear friends from Bangladesh, I am really sorry there was a technical glitch as we are having a very storming weather here, but now I can start with my presentation. So without wasting any time, I'll do so if you all allow. Can you hear me properly? Can you see my presentation and can you hear me?
Yes, sir, we can hear you.
Thank you. Thank you so much. Right. So today I would like to present some of the important, most recent and most accepted guidelines. Those are of ISSHP 2021. And I was happy to be part of this with the doyens in this field. And these the guidelines are also supported by now World Gestosis Association together with ISSHP. So the new definition of preeclampsia, we know that it was revised in 2014, and now it is further revised. Now we know that hypertension developing after 20 weeks of gestation with one or more of the following, that is proteinuria, maternal organ dysfunction, or fetal growth restriction. It is important to note that this definition does not require proteinuria always to meet the diagnostic criteria. And the inclusion of fetal growth restriction in this definition is really a significant change. What has been added in 2021 guidelines is the angiogenic biomarkers. So what is now said is angiogenic imbalance. If it is present, then that also tells us that it is pre-eclampsia. And whenever possible, this evaluation of angiogenic imbalance with PLGF split ratio should be done. This classification, of course, is the previous classification, the typical classification of gestational hypertension, chronic hypertension, preeclampsia, superimposed preeclampsia. What is to be noted is previously called atypical preeclampsia is now recognized as preeclampsia accompanied by neurological, hematological, hepatic, renal manifestations or fetal growth restriction, even in the absence of proteinuria. But what is important to us is the clinical classification rather than this textbook classification. So the clinical classifications are, of course, early onset preeclampsia, EOP, and preeclampsia, which is seen before 34 weeks of pregnancy. And the maternal complications here are much more severe, like low birth weight, fetal growth restriction, and iatrogenic prematurity. And late onset preeclampsia is the one which comes after 34 weeks of pregnancy. Another important clinical classification is that of non-severe and severe preeclampsia. And here it is to be noted that severe preeclampsia is not just only 160, 110 BP without premonitory symptoms or lab parameters, but even blood pressure 140/90 with premonitory symptoms or abnormal HDP lab parameters is also to be taken as severe preeclampsia. And it is also to be noted that it is severe preeclampsia initially may not be there. You might have a non-severe preeclampsia, but which can very easily and fast get converted into severe preeclampsia. So we have to be on the alert. So considering the magnitude of the mortality and mortality associated, it is important that we should be able to screen for preeclampsia universally and early in pregnancy. And because the tests presently available are costly and complicated, we needed to have a simplification. And that's where we came out to Gestosis World Organization as called as HDP Gestosis Score. And before I go ahead, all this is available. This Gestosis Score is available on Google Play Store, and you can download it and you use it for your daily practice also. What it involves is that this is a risk scoring, easy to use method. This score involves existing and emerging risk factors of pregnant women. Score of 1, 2, or 3 is allotted to each clinical factor depending on the severity, and with careful history and assessment, total score can be decided. And when total score is 3 or more, then patient is to be marked as high risk for preeclampsia, and prophylaxis should be started. So these are the points considered in this score, right from the age, maternal anemia, obesity, polycystic ovary syndrome, and depending on that, the score, as it is mentioned in the right column, is given. As the severity increases, like maternal hypothyroidism or family history of preeclampsia, the score given is on the higher side, that is score of 2, and in still higher risk factors like maternal chronic kidney disease, autoimmune disease, the score goes up to 3. The significance of this score is, unlike other guidelines, which consider each factor is of equal significance, the Gestosis score gives weightage according to the severity. And while completing the score sheet, it allows you to actually leave blank the places if the patient is not able to give the proper history. And what it denotes is more than actually probability of prediction, it denotes when you should start prophylaxis. And this is very important because, even if you have a few more false positives, it really doesn't matter. There are, of course, other biomarkers for prediction. This SCOPE study used 47 biomarkers and then decided with all that they can, of course, diagnose early onset preeclampsia, but preeclampsia close to term is still difficult to diagnose. Then this prognosis study in 2016 told us that a split and a PLGF ratio of 38 or lower can be used to predict the short-term absence of preeclampsia in women whom the syndrome is suspected clinically. Then, of course, this famous study by Nicolaides group with multiple biomarkers, gave us a prediction of almost 80% of early onset preeclampsia, but the prediction for term eclampsia was still low. As we can see here, when the maternal risk factors with MAP plus uterine RT Doppler, PAPI, and PLGF are assessed together, the predictivity of early onset preeclampsia is 81%, but still for late onset preeclampsia is 43% only. So what is the present consensus about prediction? The universal screening is recommended, but there is no single effective screening test. None of the tests proposed till date to predict the at-risk population for preeclampsia qualified to be recommended for general population screening. This assessment of clinical risk factors, like in gestation score, helps us to be more vigilant. So use of biomarkers. So can the biomarkers be used in diagnosis, if not in prediction? Yes, that's more useful here. The diagnosis of preeclampsia based on traditional, but non-specific and unreliable clinical markers are there, like blood pressure as a subjective value, proteinuria too. So what is important is we use biomarkers for a definitive diagnosis. And this has been proved with the Pelican study. The conclusion was that if we have low PLGF, it has a high sensitivity, at least for negative predictive value in preeclampsia. Then the MAPLE study told us that when PLGF reports are revealed to treating doctors, it reduces the perinatal mortality and small for deaths babies, but appears to lead to earlier delivery with more neonatal and respiratory morbidity. In this most recent study called as a PARROT trial, the authors found that the availability of PLGF test results substantially reduced time to clinical confirmation of preeclampsia. And this trial showed that with implementation of PLGF-based testing, clinicians make a quicker diagnosis of preeclampsia, and there is a reduction in serious maternal adverse events. So I would like to mention two other promising biomarkers which are in the horizon for predictability of and diagnosis of preeclampsia. One is, of course, Congo red test, which is a urine test which identifies misfolded proteins, and I'm sure you all know that because a lot of work is being done in your own country with Congo red testing. But another important and more specific test is the serum endoglin levels. And we have ourselves developed this placental origin receptor-based protein biomarker test with high prognostic and diagnostic value, which is presently under process of patenting, and will soon be able to make it available as a bedside test where we will be able to predict and diagnose preeclampsia with levels of serum endoglin in a card test like this. So, what about prevention? When we talk of the ISSHP guidelines 2021, again, low-dose aspirin, exercise in pregnancy, and the calcium supplementation are the ones which are recognized for prevention. What is not for prevention by these guidelines is low molecular weight heparin, vitamin C or E, or just folic acid. So, exercise in pregnancy, of course, is very important because there are, contraindications. Unless there are contraindications, all women should exercise in pregnancy to reduce the likelihood of gestational hypertension and preeclampsia, which works well. Then low-dose aspirin, we know the women at increased risk of preeclampsia benefit from receiving low-dose aspirin. However, magnitude of benefit depends on how the risk is identified, the timing of initiation and dose of aspirin administered, and their, of course, compliance to aspirin as prescribed. Now let's come to something new in management of hypertension. We know that there is a need to, of course, treat severe hypertension because that reduces the chances of intracerebral hemorrhage. But now we also know that even if the blood pressure is not very high, if it is more, just 140 or 40 by 90 or more, we should start treating by first-line treatment like methyl dopa, labetalol, or nifedipine. And why this is so? Because this CHIPS trial concluded that if you start treating early, then you are able to prevent more complications of severe hypertension later on. So this CHIPS trial told us that tight control seems to be the way forward, rather than waiting for the blood pressure to go above 150 or 160 and then trying to treat it. There are some new exciting discoveries also, and we have been working with our Indian Council of Medical Research in our hospital for last 5 years, and we have done plenty of marker studies, right from vitamin D levels, calcium levels, folate, serum, CRP levels, and PLGF, and so on. And one of the important things, this 5-year study is just getting completed, and we'll be presenting our final results to the ICMR soon. But some interesting points are there, and it seems that even vitamin D plays an important role in development of preeclampsia if there is deficiency. Then we are also working on early prediction of preeclampsia in pregnancy with cell-free RNA. Again, cell-free RNA is a non-invasive means of monitoring the mother's risk of specific organ damage, and multiple organ damage can be early diagnosed with the cell-free RNA testing. Again, we are hoping to come out with a detailed study soon on this. And of course, a very exciting discovery by Anand Karomanchi and the team. They were actually working on RNA interference therapy for preeclampsia. They succeeded in mice models, and by RNA interference, they will be able to actually treat a patient of preeclampsia who's having preeclampsia. So this will be a game changer when it comes in the market. So in conclusion, preeclampsia management presents many challenges, starting from early diagnosis, prediction, and prevention. The latest guidelines and newer discoveries are gradually improving our capability of managing gestosis in much better way, and keeping ourselves updated is the key. In the meantime, it's always good to use something, especially in our LMIC countries, something like gestosis score to decide where, when the prophylaxis needed, and go ahead with that. Thank you so much for your kind listening. I'm sorry for the technical glitch that was there due to weather conditions here. If there are any questions, I'll be available for that. Thank you so much.
Thank you, sir, for your informative presentation. Now, it's time to take comments from our Honorable Chairperson. I would like to request Dr. Sultana Parveen to say something about the session.
Thank you very much, Dr. Shafinas Mehjabin. Dr. Sanjay Gupti, as usual, enriched us with the updates in preeclampsia. Young gynecologist of OGSB, Dr. Sharmin Sultana and Dr. Taslima Akhtar have focused light on particular aspect of placenta accreta spectrum and importance of optimum glycemic control of GDM. I congratulate all of young gynecologists for evidence-based and time-demanding presentation. I would also like to request all of young gynecologists for pursue further on these topics, including research. Thank you all for patience hearing.
Thanks, Dr. Sultana, for your valuable comments. Now, I would like to request Dr. Tania Akbar to say something about the session.
Thank you. Assalamu alaikum and very good evening to all. Welcome to this important high-risk session of this prestigious conference. It was really wonderful, grateful, and brilliant presentation. Our fourth speaker, Dr. Hafiza Farzana, extraordinarily updated all the aspects of recurrent pregnancy loss and raised the concern area which need to be explored to bring success in this burning issue. Our fifth speaker, Dr. Rumaisa Taher, also gave excellent presentation on postnatal psychosis, which is most neglected area in our country and badly affect not only mother's health, but also newborn's health and life. Thank you for your outstanding ways of update all the science of postpartum psychosis according to NICE guideline. And I am really hopeful that our country psychiatry society recently developed a protocol where they address this issue and discussed and developed a national protocol too. It's my honor to chair this session where we enlightened our knowledge by our learned speakers. Thank you all for your kind presence.
Thanks, Dr. Tania, for your comments. Now, I am requesting our Honorable Advisor, Professor Samina Chaudhuri Madam, to give her words of wisdom regarding the session.
আসসালামু আলাইকুম সময় খুব কম 2 মিনিট তো প্রথমে আমি যেটা বলবো যে আমার যেটা মনে হচ্ছে যে আয় ছেলেরা আয় মেয়েরা ফুল তুলিতে যাই ফুলের মালা গলায় দিয়ে মামার বাড়ি যাই সেই ফিলিংসটা আমার হচ্ছে and this conference reduces the distance between our senior and juniors. And first of all, I want to congratulate all of you, especially the youngsters who presented. All the presentation was excellent. And in terms of your slide preparation, your presentation, and also the content of the presentation was excellent. I am very much impressed with your presentation. All of you done excellent. And this session is a wonderful session which is enriched by the presence of Professor Sanjay Gupte virtually, and definitely his presentation enriched our knowledge, and he mainly mentioned about the newer updates on definition, diagnosis, treatment, and newer researches. Thank you very much, all of you, and all the chairpersons, these young chairpersons. After their comment, I have nothing to comment about their presentation. And our advisors, all the advisors, I am requesting you, please come on the dais, because your untiring efforts on grooming this group of presenters was excellent. Because of your presence and because of your advice, they have made so nice presentation. And last of all, what I want to say that during these last 2 months, these young groups has done excellent job and given the untiring job during this period. And so I think my time is also over, and I must congratulate OGSB and our young team and everybody to saying thanks to you. And I hope every year we will be together in young gynecology session. Thank you very much.
Thank you, Madam, for your enthusiastic words. Now we are at the end of the session. We are running short of our time, so if you have any questions, please ask our honorable speakers at lunchtime. Now I would like to request our rapporteur to deliver formal vote of thanks.
Before rapporteur, I must give thanks to hall supervisor. I have gone outside and she she tracked me. Where are you going? Your term is there. And also the rapporteur and also the moderator. Excellent job you have done. Thank you very much.
Thank you very much, Dr. Shafinaz Mehjabin. It's my pleasure to thank our respected advisors, honorable chairpersons, moderator, and our presenters to run the session so successfully.
Their excellent deliberation has enriched our knowledge enormously. And thanks the audience for the patience hearing. And now it's the time for lunch break.
Assalamu alaikum. Most exciting session, that is raffle draw. Raffle draw এখনই আমরা শুরু করব। এখনো যারা raffle draw পুরস্কার পান, টিকিট পাননি, একটু জি ম্যাডাম, সবাই একটু বসুন। আমি এই পর্যায়ে আমাকে একটু সাহায্য করার জন্য আমি বিনয় রিকোয়েস্ট করব আমাদের চেয়ারপারসন সায়েন্টিফিক কমিটি ডাক্তার সুরাই আক্তার ম্যাডামকে একটু আমার সাথে আসার জন্য রিকোয়েস্ট করব। আর আমার সাথে আছেন আমাদের হেড অফ মার্কেটিং মিস্টার সরোয়ার আলম এবং মিস্টার আহসান আহমেদ, গ্রুপ কোঅর্ডিনেটর, গ্রুপ প্রোডাক্ট ম্যানেজার অফ হরমোন টিম। আমি ম্যাডাম কি বলেন ম্যাডাম? জি, আমি আজ এই পর্যায়ে বিনয় রিকোয়েস্ট করব আমাদের শ্রদ্ধাভাজন প্রফেসর ব্রিগেডিয়ার জেনারেল সুরাইয়া রহমান ম্যাডামকে মঞ্চে আসার জন্য। পাশাপাশি প্রফেসর ফিরদাউসি বেগম ম্যাডাম, প্রফেসর দীপ্তি বড়ুয়া ম্যাডাম, প্রফেসর বেগম নাসরিন ম্যাডাম, প্রফেসর তাবাচ্চুম পারভিন ম্যাডাম, প্রফেসর শামিয়া রায়নি ম্যাডাম, and প্রফেসর নিয়াজ টি পারভিন ম্যাডাম, প্রফেসর রহিমা বেগম ম্যাডাম, প্রফেসর আজিজা রহমান ম্যাডাম, and প্রফেসর আক্তারুন্নেসা ম্যাডাম, and প্রফেসর জাহানারা ম্যাডাম। আপনাদের সকলকে বিনয়ভাবে রিকোয়েস্ট করতেছি মঞ্চে আসার জন্য। আমাদের এই পর্যায়ে র্যাপিড ড্র এক্সাইটিং সেশন, সেই পুরস্কার দেওয়ার জন্য একটু মঞ্চে আসার জন্য বিনয়ভাবে রিকোয়েস্ট করছি। আবারও আমি নামগুলো ঘোষণা করতেছি। শ্রদ্ধাভাজন প্রফেসর ফেরদৌসী ম্যাডামকে মঞ্চে আসার জন্য অনুরোধ করছি। ব্রিগেডিয়ার সুরাই ম্যাডাম রহমান, প্রফেসর দীপি বড়ুয়া, প্রফেসর বেগম নাসরিন ম্যাডাম, প্রফেসর তাবাচ্চুম পারভিন, প্রফেসর শামিমা রায়নি, প্রফেসর নিয়াজটি পারভিন, প্রফেসর রহিমা বেগম, প্রফেসর আজিজা রহমান, প্রফেসর আক্তারুন্নেসা, এন্ড প্রফেসর জাহানারা ম্যাডাম, আপনাদের মঞ্চে আসার জন্য অনুরোধ করছি। জি জি ম্যাডাম, জি ম্যাডাম, ওরা একটু আসুক, আমাদের হেড অফ মার্কেটিং একটা মিনিট আমি দেবো, একটু সবাই আসলে। না, ওরা সবাই দাঁড়াইলেই আমি দিয়ে দেবো। আমি একটু বলেই আমি দিয়ে দিচ্ছি আপনাকে, আমি হ্যান্ড ওভার করব। জি জি জি।
May I request all our honorable madam to come upon the stage. Professor Surai Rahman madam, Professor Ferdousi Begum madam, Professor Dipi Borua madam, Begum Nasrin madam, Professor Tabassum Parvin madam, Professor Shamima Raini madam, Professor Niyazti Parvin madam, Professor Rohima Begum madam, Professor Aziza madam, Professor Akhtar Unnasa madam, and Professor Jahanara madam. Please, madam, come up on stage. I also invite Brigadier Brigadier Hasina madam. Please, madam, come up on stage. And Professor Diluba madam. Madam, ওরা একটু বলতে চাচ্ছে।
সর্বমোট 8টি পুরস্কার আছে। সর্বমোট 8টি পুরস্কার আমাদের এখানে আজকে র্যাপিড ড্রতে। ধন্যবাদ আমাদের আজকে সুযোগ করে দেওয়ার জন্য। আমাদের সাথে আছে আমার হেড অফ মার্কেটিং মিস্টার সরোয়ার আলম, ওনাকে একটু এখানে আসার জন্য অনুরোধ করবো এবং 1 মিনিট কথা বলার জন্য অনুরোধ করবো, প্লিজ।
ডিয়ার ডক্টরস, আসসালামু আলাইকুম। স্কয়ার ফার্মাসিউটিক্যালস পক্ষ থেকে আপনাদের অসংখ্য ধন্যবাদ আমাদের আপনার সাথে থাকার জন্য, এবং আমরা আশা করছি স্কয়ারকে যে আপনাদের সুযোগটা দিয়েছেন আমরা কামিং ডেজে সেটা আমরা মেনটেন করব। আর আমি আশা করি আমাদের যে রেফারেল প্রোগ্রামটা আছে আপনারা এনজয় করবেন এবং আপনাদের মনে থাকবে। থ্যাংক ইউ ভেরি মাচ।
প্রথম পুরস্কার আমাদের সবগুলাই গিফট ভাউচার। ফার্স্ট পুরস্কার 50,000 টাকার গিফট ভাউচার ট্রান্সকম। সেকেন্ড পুরস্কার 45,000 টাকার, থার্ড পুরস্কার 35 এবং ফোর্থ পুরস্কার 30,000 এবং লাস্ট চারটা 10,000 টাকা। আমি ম্যাডাম গিফট ভাউচার 8টা। আমরা সর্বপ্রথম 8 নাম্বার পুরস্কার আমরা তুলব। আমাদের পিএমডি ম্যানেজার মিস্টার আহসান আহমেদকে রিকোয়েস্ট করবো 8 নম্বর পুরস্কার তোলার জন্য। ম্যাডাম কে দিবে তার নাম আপনি বলেন। কে দিবে তার নাম?
এই যে প্রফেসর জাহানারা ম্যাডাম, না প্রফেসর জাহানারা ম্যাডাম এন্ড প্রফেসর দিলরুবা ম্যাডাম, দুজনকে ডাকি। প্রফেসর জাহানারা ম্যাডাম, ওনাকে অ্যানাউন্স করতে বলে। আমি এখন প্রফেসর জাহানারা ম্যাডাম এবং প্রফেসর দিলরুবা ম্যাডামকে সামনে এসে আমাদের 8 নম্বর বিজয়ী ভাগ্যবান তার নামটা অ্যানাউন্স করার জন্য অনুরোধ করছি। দিলরুবা নাম নাম্বার হ্যাঁ,
ব্র্যান্ড নেম অরিলিভ 200 আর হলো কোড নাম্বার 192 অরিলিভ 200।
আচ্ছা, স্টেজের সামনে প্লিজ সবাই বসে পড়ো, না হলে বের হয়ে যাও।
অরিলিভ 200,
সামনে দাঁড়িয়ে থাকা যাবে
কোড
না।
নাম্বার 192। কাউকে পাওয়া যায় নাই? হ্যাঁ, আরেকবার বলছি, অরিলিভ 200, নাম্বার হলো 192। পাওয়া গেছে? আছেন কে? আসেন আসেন।
আপনারা তোমরা যারা হয় বসো, না হলে বের হয়ে যাও প্লিজ। এখানে কোনো ডিসিপ্লিন দেখা যাচ্ছে না। সময় যায় না।
আমি প্রফেসর আখতারুন্নেসা ম্যাডামকে অনুরোধ করছি আমাদের নেক্সট রেফেল ড্রটা তোলার জন্য। 7th পজিশন। জাহানারা ম্যাডাম 192 আমাদের 8 লাকি উইনার।
আমি 8 লাকি উইনার।
এটা কি 7th না? Again এটা
ওনার প্রাইসটা অ্যানাউন্স করুন। প্রাইসটা কি?
অষ্টম পুরস্কার 10,000 টাকার গিফট ভাউচার। সর্বনিম্ন অষ্টম পুরস্কার 10,000 টাকা গিফট ভাউচার।
আবারও সেই সপ্তম পুরস্কার অরিলি 200, নাম্বার 214 অরিলি 200। লাকি অরিলি মনে হচ্ছে। অরিলি কি খুব 7, নাম্বার 7, লাকি 7, অরিলি 200, নাম্বার ইজ 214। 214। Next.
I am here. আমাকে 2টা কুপন দিয়েছে। But be assured, I have never got a prize. আমি এখানে রাইখে দিলাম, পাবো না। যদি পাই তাহলে আমাকে তার পুরস্কার দিতে হবে। Keep it. I'm very confident I'll not get anything. So the next one, please. It has to be quicker. Yeah. So on behalf of Akhtarunnisa, Aurelie 200 again. Last number is 7. First number is 2. The middle number is 8. 287, Aurelie 200. So yeah. Please come on. Please come up to the dais. So by that time, what is this inside? Gift daughter of 10,000 taka. I'm keeping it, okay? I hope you don't mind. Please go ahead. Thank you. For the next, I am calling upon Nearest Department. Please come here. Sixth prize. Six. Just be quick. The lunch is waiting. Yeah. So, ঠিক আছে কিনা মিলাই দেখেন. No ফাঁকিবাজি মিলাই দেখেন. Sorry. Yeah, Nearest Department, come here. Already 200 again. The last number is 3. The first number is 4. And what is the middle number? 5. So it's 453. Already 200, 453. Anybody? Yeah, we got one. The lucky person. What is here? Same here. 10,000. So I have 20,000 by the time. Thank you so much. Yeah. So the next, for the next. আচ্ছা ও যে পেলো মাঝখানে ওর নাম কি শুনেছিলাম আমরা না আচ্ছা আসো 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 তোমার নাম কি Professor Aziza from the northest part of the country, Rangpur. President Rangpur branch, yeah, please. Dr. Rina Nasrin from Enam Medical College. Okay, so yeah, 6th. So that's the 6th prize. Now for the 5th, right? Now for the 5th prize. 6th. এটা 6 না 5. এখন কোনটা ড্র করছি আমরা ও তুলবে তো Okay. So let us see who is lucky with Dr. Professor Aziza. The first number is 5. The last number is 2. And the middle number is a big 0. So it's 520. 502. Sorry. 502. Who is there? Orally 200, 502. 5021. 5022. 5023. Unfortunate. So again, please. এগুলো রাখেন হ্যাঁ ঘুটা জোরে ঘুটা এই মুখ বন্ধ না করে ঘুটা দিচ্ছেন কেন কি মুশকিল পাত্রের মধ্যে একটা ফুটা গেছে ভুলে গেছেন ঘুটা দিচ্ছেন ইয়া প্লিজ আজিজা নর্থ বেঙ্গলে দেওয়ার চেষ্টা করতেছে সেই জন্য the first number is 1 the last number is 2 and the middle number is 8 182 orally 200 182 wow so are you from North Bengal সূক্ষ্ম কারচুপি হচ্ছে কিনা দেখা প্রয়োজন কোথা থেকে দেখেছো রাজশাহী মেডিকেল কলেজ ইটস এ কনস্পিরেসি নো ওয়ে yeah definitely it's a conspiracy transparent conspiracy so next I'll call upon Dr. Professor Tabassum Parveen please Tabassum our dear sister Tabassum Kiran
একটু বলে নেই আমাকে আশেপাশ থেকে বলছে তাদের নাম্বার না উঠালে খবর আছে আমি ভয় ভয় আছি
okay so this is 4th prize keep your fingers crossed Dr. Burke have you crossed your finger 30,000 because the prize goes to me if you get it yeah so this is 30,000 taka my goodness so it's quite a lot prize. The amount is 35,000. Quite a lot. So, Surapa তুলেছিলেন? Please, Appa. Oh, Surapa first. DP Borua. আমাদের খাদ্যমন্ত্রী, the food minister. ভালো করে ঘুটা দিয়ে।
আমাদেরটা তোলেন ম্যাডাম, এখানে দাঁড়িয়ে আছি।
দীপি আমারটা না তুললে দীপিকে খাইতে দেওয়া হবে না। Okay, so the number is from the river side 142. I mean 241. The lucky number. DP, this is not right at all. This is not right. How lucky! Congratulations, madam. Okay.
This is the first time I got.
Oh, apa tale amiও পেয়ে যাইতে পারি।
জীবনে তুমিও first prize.
Thank you, madam.
Yeah. Congratulations, madam. Please have your prize. So this is third prize.
This is the lottery I got first time in my life.
So I have some hope at last. Yeah. Thank you, the team. Now, the amount increasing in an exponential way. So the next prize is 45,000. I am happy that you are giving money because instead of this, devices, so that sometimes is okay. So who is drawing this second prize? No. জাহানারা আর কে বাকি আছো?
বেগম নাসরিন ম্যাডাম, বেগম নাসরিন
না, আনি।
দীপির বাড়ি চিটাং, তো ওই জন্য আমারটা তুলছে।
ও দীপির বাড়ি চিটাং, ওই জন্য সাহেব ব্যাপারটা তুলছে, গোপনে বলে গেলেন আপা। অ্যানি এন্ড না জাহানারা রুমা দুজন তুলো। ইয়া কাম, দুজন আসো। হ্যাঁ, একটা টিকিট নিয়ে আবার টানাটানি করো না, দুইটা নিয়ে একটা। সরি। আর এই ফুটার মধ্যে ঘুটা। আপনারা কিন্তু দেখতে পাচ্ছেন সম্পূর্ণ ট্রান্সপারেন্ট বক্সে করা হচ্ছে, সুতরাং নো কনস্পিরেসি, নো কারচুপি। ওকে, প্লিজ গো হেড। সেকেন্ড প্রাইজ ওয়ার্থ 45,000. Number 1, 2, 3. Keep your fingers crossed. Oh my goodness. I hope it's not me. The middle number is a big 0. The last number is 8. And the first number is humbly a 2. So the orally 2,000. Already 200. I have given a bonus 2,000. Already 200. The number is 208.
208.
Wow. Come on. Yeah, so who gives this? এই ইয়ে কোথায়? আমাদের গুলশান আপা কই? গুলশান আপা আসেন। গুলশান আপা স্টেজে আসেন। আরে সেক্রেটারি জেনারেলকে রেখে দিয়েছে কেন? গুলশান আপা, বেগম নাসরিন চলে আসো স্টেজে। So our lucky fellow, lucky member of OGSB.
I am Dr. Sharmin Sultana, Assistant Professor at the Women's Medical College, Mogbazar, Dhaka.
Okay. এই যে শোনো, মুনমুন 50-50.
Thank you, madam.
Okay, so
এটা আমার জীবনের প্রথম রেফেল ড্র পাওয়া।
So I have a big hope. Thank you. So finally, the first prize. এই গিফটটা কে দিবে? দিয়েছে ওরা দিয়ে দিয়েছে। এই ফার্স্ট প্রাইজটা আমাদের আপা তুলেন, সুরাই ম্যাডাম তুলেন প্লিজ। Okay, so we have this Surapa diben gift. এই আমারটা দেখি,
নাই
আমারটা নাই। See, I have seen that. I have shown, I was confident that I'll get one. And finally, I didn't get it. So the middle number is 7. So there is a big sound. The many middle number is 7. And it's orally 200, of course. And then last number is 6. And the first number is 2. Oh, so it's 276 orally 200. Wow, please come ahead. চলে আসো। এবং প্রথম পুরস্কারের value worth of $50,000 US.
বাকিটা ম্যাডাম দিয়ে দিবে।
Or it may be Great Britain pound. 50,000 taka. Please come here. আস্তে 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 আমার মনে হচ্ছে অনেকবার প্রায় পেয়েছে, আসার কোনো ইচ্ছা নাই, তো আমরা ভাগ বাটোয়ারা করে নিয়ে নিতে পারি যারা স্টেজে আছি। অনেক টাকা ভাগে পড়বে, কিছু কিছু 500 করে তো পড়বে at least. Congratulations, a big congratulations, and we let us the chance to thank all of our sponsors, especially Dr. Square Pharmaceuticals, to have this raffle draw. তোমার নাম বলো, আসো কথা বলো।
Assalamu alaikum. আমি Dr. Tahmina Afrin Daisy, Associate Professor from Institute of Child and Mother Health, Matwail.
ওটা সরাই ফেলান, ওটা সরাই ফেলান, ওটা সরাই ফেলান। ম্যাডাম আপনারা সবাই জানেন সেটা প্রথম বলে দিন। আপনারা সবাই জানেন। ম্যাডাম দান, কুশন দান। ম্যাডাম দান।
পলস সেশনটা আমরা কয়টা শুরু করব?
ম্যাডাম কয়টা বাজে এখন?
এখন বাজে 1:52, আমাদের দুটো টাইম।
আপনারা সামনে আসেন।
একটু সেকেন্ড দাঁড়া। So this is the end of the lucky draw, raffle draw. So we congratulate each and everyone for this. এখন কয়টা বাজে? 1:53. Lacking behind the time, Professor T. Chaudhary sir is here. Sir, assalamu alaikum. Sir, ekটুর জন্য first prize টা miss করছেন sir. Raffle draw first prize. Thanks everyone. We will start the panel discussion sharp at 2:30. Policy session sharp at 2:30. So we want everybody have a quick lunch. Very quick lunch.